We'll get started. Hello, everyone. Welcome to the second part of our CME program today. We welcome you back. For those of you who are joining us for the first time, I hope you had a chance to listen to the first part that was sent out. The recording of it was made last week. If you haven't had a chance to do that, they'll be resent after this one, along with the recording of this second session. I welcome you as the Executive Director of our Stanford Health Communication Initiative. Advance the slide, please. The Stanford Health Communication Initiative, to remind you, is embedded in our Stanford Center for Health Education at Stanford Medicine. Slide. The purpose and goals, just to recapitulate, are to develop improved techniques of communication for health and medical issues, to develop strategies and tools for effective communication of health information and mitigation of misinformation, and to improve methods for healthcare professionals for effective communication of scientific information with the media, and to increase research and education in these essential areas. Slide. Our learning objectives for both of these sessions are to discuss the different categories of false health news that comprise what we call information disorder, to recognize health information and disinformation and counter false narratives using effective communication techniques, and to translate technical language and uncertainty into language accessible to a lay audience. Slide. To build relationships with the press to convey accurate, nuanced health information, discuss publishing ecosystem, including book publishing, podcast, and written journalism, and to develop public-facing platforms as a published author and writer. Slide. As I mentioned, there'll be a recording of today's webinar, and it'll be available by tomorrow, and you'll be receiving both recordings again tomorrow, and you can share them with your colleagues and friends. Slide. The email address you use to register for this webinar will be used to verify your attendance and award CME. After the webinar, you can receive an email containing the link to an evaluation and instructions for claiming CME. Within the evaluation, you'll be asked to attest to your hours of participation. Please allow 2 to 3 business days for your CME certificate to become available via your cloud CME account. Slide. The format for today's session is to start with a recap of part 1, and then conduct a skills workshop for part 2 to learn to build compelling and credible public role and how to manage your own risk. There'll be plenty of time for Q&A, and I remind you to please use the Q&A function on your screen to ask questions, and we'll try to get through as many of those as possible, hopefully all of them. We'll have more time for that and for interaction today. Slide. So we're happy to introduce again our 2 internationally well-known speakers who are experts in this subject. Rob Steiner, who introduced last time, is the director of the Dalai Lama Fellowship in Global Journalism at the University of Toronto. Slide. And Seema Yasmin, who works with me as a director of our Stanford Health Communication Initiative. And we're going to start with Rob and a recap slide. Go for it, Rob. You're on.
Thanks so much, Jonathan. So joining you from Toronto, and I should just start by acknowledging that I'm actually joining you today from the traditional territory of 3 First Nations in Canada, the Huron-Wendat, the Haudenosaunee, and the Mississauga, the New Credit First Nation. And Toronto in this area continue to be a meeting place for First Nations, Indigenous peoples from across Turtle Island or North America. So thank you so much for having me back. I'm just going to try to recap very quickly in about 5 minutes some of the stuff that we had last week. And again, as Jonathan was saying, all of that material is available in the recordings. I started off really by saying that, there are two problems that I think constrain communications in the midst of this pandemic. And I should note that when I'm talking here, although I'm sitting in Canada, Canadians are almost as involved in American politics and the American situation as Americans are. We read all the same things, watch all the same news. So we're watching very carefully. And I am actually, to be fair, speaking mostly about the American context here. But I know that there are a lot of folks who are joining from other countries and other communities. And I think that these dynamics probably play out in different ways elsewhere in the world. I know that in Canada they do as well. And so I'll just invite you to sort of consider what is relevant of this for your own community. The other thing I do want to just say, because I'm not in the United States, it's easy for us to sit here in another country and watch and sort of assess. I think it is, and I should just say this sort of very personally, heartbreaking, actually. And I want to be very humble about anything that I say here today. Not to suggest that for our American colleagues who are joining us here, trying to provide good quality healthcare, that this is easy. Maybe even it might even feel undoable under the current circumstances. And so, take this for what it's worth, and as a bit of some thoughts and a bit of a love letter from north of the border. So I think that there are two, and I know that by the way, there are folks who are joining from India, from Brazil, from South Africa, where I think many of the same political dynamics are actually playing out in different ways. So I think that there are two basic problems that constrain the communications context. One is polarization, and political polarization, I think we could safely say now, is a public health risk. It is one of the reasons why in the United States, the first wave is continuing in such a dramatic fashion in parts of the country that didn't experience it full bore in the first stage. Facts alone, this is important. Facts alone don't address a polarized dialogue. Fact, if you just pour facts into a polarized conversation, it's sort of like pouring fuel on a fire, because polarization indicates that there's deep personal meaning involved in the issue. It's not just about facts. But polarized conversations have a fatal weakness, right? They operate like a predictable dance. And you can shock a predictable dance by not giving the predictable answer. If you can shock a predictable dance with new facts or more the point, a new framework that is equally accessible to a wide range of people in the conversation, you can stop this polarized thinking for just long enough for people to remind themselves to think and to think in a different way. The example that I pointed to was how HIV/AIDS, when that was the infectious disease reshaping North American culture, reshaped also and reframed the larger conversation about inclusion of LGBTQIA people. Because now we were no longer talking about morality, we were talking about safety and public health and lives being lost. I used to be a reporter in South Africa at the late stages of apartheid. The conversation about apartheid in South Africa became, for a moment, for about 10 years, depolarized, because both the ANC and the supporters of the white regime started talking about something else. They started talking in the same way about the economy. And that actually was an opportunity for them to come together. Journalism is a tool here to depolarize a conversation, because seeing like a journalist, even if you're a physician or a nurse or another health professional, seeing like a journalist allows you to find counterintuitive stories that are going to be equally important to a wide range of people across these divides. Journalism thinking and journalism seeing helps folks find topics that will shock the system and be equally accessible. The second risk, just very quickly, that constrains conversation right now, I think, is that CDC protocols that folks were adhering to at the beginning of the outbreak, not just in the United States, but around the world, I think are now no longer appropriate. There is a set of protocols that most public health professionals know, which is essentially command and control. We're in an emergency, brace, 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 listen to one voice, it's a public health voice. She or he will tell you what to do, period, and follow it. Public health in the lead, not politicians, and so on. That works when you have an acute problem with an acute specified population where most of the facts are known, a natural disaster, for instance, or maybe a very well-known pathogen like an influenza variant or something like that, where the CDC or the public health authority can speak with authority for a period of time. And where the problem itself is limited, it's constrained, it's a Legionnaire's disease outbreak, it's not all of society. We're in a very different situation now, where the problem is chronic. Whether or not this virus is endemic officially, we all agree it'll be with us for a very long time. It is misunderstood, or not well understood, not misunderstood, but we're still learning a great deal about it. There is no single source of authority, and the context is massively complex. So this is all much more akin in the clinical setting to working with a chronic patient who has a chronic disease with a whole lot of comorbidities and a complex biopsychosocial situation around them. And we know from clinical medicine that the best thing that works there is patient-centered care, where the physician or the caregiver, the care team, takes a holistic view of the patient, not around one pathology, works in an integrated way across the team, bringing in all sorts of different assets, where the caregivers and professionals are humble about what they know and what they don't know, and they work with the patient as a partner. Journalism, again, here, journalism seeing allows us actually to try to adapt the patient-centered care model into population health, I think probably for the first time, because journalism seeing actually allows us to bridge our silos, to work beyond a single silo, integrate a view, and listen to the population the way that a patient-centered care team would listen to the patient and his, or their family. So I think journalism is an asset here. We did an exercise last week where we looked at three things. I'm just about to wrap up. We looked at what makes for those kinds of breakthrough stories, something that is counterintuitive, something that is important for your target audiences, which need to include folks who are not just the folks in your own corner, which really implies that you have to understand what is motivating the people who are not sympathetic to you, and that's timely. We've noticed, we teach this stuff at the University of Toronto. This will be my little plug. Stanford Medicine teaches it. We teach it. So we do an intensive program that will actually be starting in September for 8 months. My colleague Seema is a graduate of it. So if anyone is curious about that, please feel free to email me. I'll put up my email in the chat. But when we teach it, we notice that it actually changes clinical culture in a number of ways. So that's basically it for me. I think I went a minute or so over. My apologies, Seema. Over to you.
No problem. Hi, everybody. Welcome. I'm loving that we are seeing people join from the Philippines, from India, from so many different parts of the world. So thank you very much. Keep your questions coming. Rob and I will be checking those intermittently. We want this to feel as interactive as possible. So for my recap of what we covered last Tuesday, after Rob talked about polarization of conversations, I talked about how a very polarized environment is extremely fertile ground for misinformation and disinformation to spread. And as Rob mentioned, when you have that kind of polarized environment, just saying, well, somebody is spreading untruths, I'm going to throw facts into that conversation, it doesn't work. I also mentioned that I'm very careful and very deliberate to not use the term fake news. And that's because that phrase has been weaponized to diminish and to demonize journalists and journalism. So you will hear me use it only when I'm referring to it in that context. And that's why I was very careful last week to share with our whole group some very specific definitions of different kinds of falsehoods. And I think it's important to start with those definitions because that's a great starting point of describing a problem before you think about how to tackle it. So let me share those definitions with you again. I talked about misinformation. Misinformation is false information, but false information that's spread without any bad intent. It might be your neighbor saying, hey, I heard if you eat loads of garlic, you won't get COVID-19. They're not trying to hurt you by sharing something that's not true. They're trying to help you. But in any case, that information is not true. Eating lots of garlic will not protect you. Misinformation is different to disinformation. Disinformation is also false information, but it's false information that is spread with the intention to cause chaos and to cause harm. So one example of that might be bad actors, foreign governments, seeding bad information online, saying things like there's an Ebola outbreak right now in Atlanta, which they did spread that disinformation during 2014, 2015, saying, creating false websites that look like news websites, sharing this false information and doing it deliberately to cause mayhem. They want emergency services to be diverted. They want chaos. They want people to be very scared. Then you have malinformation. Malinformation is actually different because it's truthful information. It's actually accurate information, but it's spread with the intent to cause harm. So malinformation might be hacked emails. It might be patient information that should be confidential, but that's shared, and it's done so with the intent to cause some kind of chaos or havoc. So that's misinformation, disinformation, malinformation. And collectively, we talk of those as information disorder. And information disorder is a helpful thing to categorize in this one group because it shares transmission characteristics with disease. So what do I mean by that? What I mean is at the same time as we're seeing SARS-CoV-2 spread from one person to another, we're also seeing information disorder spread from one person to another. Information is contagious. Emotions are contagious. And when I talk about information disorder sharing transmission characteristics with a disease, what I mean is even more than just that similarity of person-to-person transmission or point source transmission, you see things like super spreader events. You may have heard of super spreading in the context of this new coronavirus. It's the phenomenon where maybe around 20% of infected people are responsible for 80% of transmission. And these super spreaders might be spreading at a much higher rate than others because of some immunological or biological characteristic, or it might be something to do with their life. They might be a kindergarten teacher. They might be someone who's really social. They might be somebody who's not wearing a mask or following shelter-in-place guidance. It's kind of complicated. We still don't really fully understand why some people start these super spreading events. But in any case, in the same way that you see super spreading events for disease, you see super spreading events for information. It might be that there's a celebrity who just has millions of followers on social media, and so they become super spreaders of information disorder. So we talked about that. We talked about the utility of the specificity of those definitions, not saying fake news, because as I mentioned, it's used to diminish and demean the work of journalists. And then I talked about the role of journalism as an immune system of a democracy. And I peeled back the curtain a little bit, I hope, and you can watch that video if you haven't seen it. It's on YouTube, where I just peel back the curtain a bit on the processes of science journalism. And to Rob's point, I say that journalism and a journalistic perspective can help to depolarize these environments, but that because of some shortcomings, sometimes journalism can further fuel that polarization. And that might be because of problems of false equivalency. It might be because we use such narrow sources, people who look the same, sound the same, have the same perspectives. We're not offering readers that broad perspective and telling the full breadth of a story. So that's my wrap up of what we covered last week. Before I jump into the next part of the conversation, I want to see if there are any questions relevant to our recap. If any of you who joined us last week or caught up on the video had any further thoughts that you want to share with us. Rob, did anything come to mind for you, or did you see any questions?
I've been looking for questions. I don't see any there, and I've been looking at the chat too. So just a reminder to folks, if you have any questions at all, throw them into the Q&A box at the bottom. The chat box is really for sort of technical issues where our colleagues who are running the wires and the plumbing and everything in the back office are going to help you with that. But throw questions into the Q&A and I'll look again. I don't see anything there, Seema.
One thing I'll add in my recap before I go into the next topic was when I talked about misinformation, disinformation, and malinformation, after I left you with those definitions, I then kind of disrupted our whole thinking of it, because then I shared a couple of examples of accurate information gone wrong because of the way it was communicated. And I think this is really enlightening because it reminds us that even as scientists, as healthcare practitioners, as community members who want to promote good information, when that information is shared in particular ways, it can cause problems. So the two examples that I shared, one was from the 2014 to 2016 Ebola crisis, where American and European aid workers went into West Africa and said, this disease is real. If you have these symptoms, please come to an Ebola treatment unit. And by the way, there is no cure and no vaccine for Ebola. That was completely accurate. At that time, 2014, 2015, there was no treatment. There was no vaccine for Ebola. But when I was reporting in West Africa, I learned the consequences of that communication, where people said to me, well, when they said that there's no treatment, I thought, why go to them? Let me go to another healer who says they do have a cure. So I use that example to highlight how complicated this is, that even when the information is completely accurate and based on science, it can have negative impacts that we don't always foresee, and we should try to foresee them. The other example that I shared was about thimerosal, which was removed from vaccines, even though it was thought to be safe. And the messaging around that was, we are making safe vaccines even safer. And actually there were negative public health consequences of that action and of that messaging, because it really confused parents, it confused doctors too. They were saying, wait, maybe this thimerosal thing has been dangerous all along, and that's why public health officials in the US are rushing to remove it. So I just want to highlight those two examples too. And if you want more in-depth discussion of those, you can go back and watch the video from last week.
I saw, Seema, there were two questions, both from Sunil, and one was a worry, and I want to thank you for expressing this, a worry about safety of journalists, and also Sunil noting any attempt to correct misinformation seems very risky in a polarized world. Let me just address both of those very quickly. Yeah, first of all, this is not a safe context for journalists. And, you know, there are physical threats now to journalists that in democratic environments that, you know, certainly didn't exist when I was an active reporter in the United States, in Hong Kong, in Japan, in Canada. And even, frankly, it feels in some ways more dangerous than when I was a reporter in South Africa. In some ways, just given the sort of nature of individual rage at journalists. But it's also unsafe, and I think this may be the bigger danger that a lot of people feel about stepping up. It feels psychologically and emotionally unsafe, right? That stepping in front of these issues in a highly polarized environment attracts such anger and rage. People become targets immediately. If someone's, and that's not just from the right, that can also be from the left. If someone uses a code word that they don't realize is a code word, then they can be canceled. You know, it is a scary context. So a couple of quick thoughts. First of all, one is to acknowledge it and thank you for raising it. The second is to say that, you know, journalism itself is a bit, provides a bit of a safety factor. There is a difference between jumping out and expressing one's own thinking and one's own ideas and trying to impose one's own thinking, as right as it may be, on the rest of the world, and going and actually reporting humbly, asking questions, and then presenting folks, you know, humbly with what one has found and the synthesis and integration of what one has found. In the latter role, you are a messenger. You're not the protagonist. You're also, you know, you'll also discover things that you may not have known when you get outside of your own head. That's why I like journalism a lot more than opining. And I would encourage folks to ask a few questions first, get outside of their own head, and then put what they've found out there and do so in a humble and tentative kind of way that encourages the conversation. And then, yeah, when inevitably people sort of throw themselves at you, one has to have a bit of a thick skin in this context. Again, I have to be very humble about this, because I'm offering all this advice from the safety of a country that is not experiencing this level of polarization and violence. But, you know, take that for what it's worth, I hope. I see there are more questions there, so I'll move on.
I'd like to respond to that too, Rob,
Yep.
because Neil has shared this really awful article with us in the Q&A about just how dangerous it is to be a journalist in India. And in the context of COVID-19, it's become more dangerous. There are journalists in India who faced personal threats to their lives and their families' lives because they are reporting on the government's inept response to the pandemic, because they are talking about the deep Islamophobia in the Modi administration and how that's panning out during the age of COVID-19. But the reason I bring up that fake news term as well last week and this week is because that's a term that's being used right here in the US, where I work as a journalist, and where it's becoming dangerous for Americans to practice journalism. I think it was last year that there was a press freedom report that actually listed America as one of the top places in the world where it's most dangerous to be a journalist. And partly that was because of the tragic mass shooting in an American newsroom not that long ago.
Yeah.
So this is definitely a problem in many parts of the world. It hasn't been that long since the Philippines had a massacre of journalists where they were buried in a mass grave. That was just about 10 years ago. And so when I talk about journalism being the immune system of a democracy, that medical metaphor where journalism is so important at all times, but to me, it feels really important right now in the age of a pandemic and multiple infodemics. That's happening on the backdrop of journalists losing their jobs, being furloughed, having pay cuts, and having their lives threatened for doing their work. And then this question right at the end from Sonia Galvin, where she says, for a long time now, just telling the truth about certain medical or scientific issues is seen as political. And then in the chat, someone has said something similar. We're going to get to that because Rob and I are speaking on exactly this issue of political advocacy, of issues around advocacy at the end of this webinar. So thank you for raising that. Rob, is there anything else you want to address before I go into my...
Yeah, there are, and I'll try to consolidate three separate questions into one thing. So all of these sort of reputational and risk things we will actually be spending a fair bit of time on. Let me address just a couple other things. Somewhat related to that is a question from Katrine about the comment section. And whether the comment section can actually distort the journalist's point. To be honest, I rarely hear the comment section becoming, if you will, infecting the rest of the thing. The comment section is a comment. I'm not sure how many people read it. I have a feeling that it is just sort of off on its own world, and the folks who like to live in that space live in that space. I ignore it. Frankly, I ignore it, except as a journalist, I sometimes look at it just to see if there are new interesting story ideas that come up out of it. But by and large, I ignore it and let them spin off into deep parts of the galaxy that I don't want to visit. Question about fixing. What do you do if you have to fix a point? How do you do that without risking your credibility? In my mind, you do it exactly by fixing the point. Fixing a point, humbly explaining where the problem came from, and introducing the correction is actually a way to enhance credibility in my mind. And again, to do it humbly, one would do that as a physician, one hopes, or as a nurse, or as a health scientist, and equally as a journalist. Simply sticking with something that is evidently wrong and hiding behind it because one said it does not enhance one's credibility. So I think quite the opposite. And the last question here, sorry, there's more coming in, but the last question that I just want to jump onto is from Jane. What can we as average healthcare professionals tell that there's no such thing as an average healthcare professional, by the way. Every healthcare professional is above average. I know that's not mathematically possible, but I believe it. Tell the layperson in private or casual conversation where to look for reliable information, to only go to reputable medical websites, reliable media, and so on. I would suggest that you, first of all, share with them what you read. We might not, as lay people, and I'm a layperson, be able to read these scientific papers, but most journals have commentaries. A lot of journals have really good podcasts. The BMJ has a great podcast. The Lancet has a great podcast. In terms of mainstream media in the United States, you will develop your own sense, I think, of what seems to be reliable and discount. From time to time, folks will make mistakes, but do they own up to them? I've been impressed, very impressed in the United States by the Times, the Post, and the Atlantic very much. Globally, I've been very impressed by the Financial Times as just sort of, contexts that are providing reliable information. So I would frankly just suggest the things that you read and that you trust, and ask them to share the things that they're finding good. It's not a specific answer other than those titles, but trust yourself for that judgment. I think that's it on this topic. I see there are a lot more, and I'll try to answer them as you go on, Seema, into your thing. But we should probably jump into the rest of the thing, and I'll just keep an eye on the Q&A.
Okay, thank you, Rob. And I will say, just before we started this webinar, I was on CNN talking about the COVID-19 situation here in the US. And it was live TV. And at one point, I said something and I thought, oh, did I just say the data the wrong way round? Did I just say that the states that mandated masks saw an increase when I meant to say decrease? And I figured out I hadn't misspoken. But even in moments like that, it's completely okay to say, oh, in case I just misspoke, I want to be really clear. What we need to remember is that states that mandated masks are a reduction, and you can repeat yourself. It's okay, you are human. I used to be really nervous about that, but I think in the moment, it's much more important that you get the point across. And so it's important to just take a minute and say, oh, in case I misspoke, or I just want to reiterate what's a really important point and make sure that your viewers have clarity. Somebody raised that important, interesting point, I think, about someone on PBS correcting misinformation from years ago, but then that's kind of still misinforming their viewers. It can be tricky. You don't want to confuse people, but I think there's always space to say, hey, I may have misspoken, I may have made an error. Let me clear that up now. And I think audiences, by and large, appreciate that, as do patients, when you're talking to them and you say something and you're like, wait, let me just go check that. It reminds people that you're human, you don't know everything, but that you're a diligent human who's really endeavoring to get them accurate information. Okay, so thank you very much for the questions. We love for this to be interactive, know what you're thinking as we're talking. But let me launch onto the next slide and the next part of this webinar, which I think is from high demand of people just saying, look, there is so much misinformation, disinformation out there. How do I start these difficult conversations where I want to share accurate info, but I'm doing so in a polarized environment? So let's envision a conversation, perhaps either with a patient or a relative who is sharing stuff that is anti-vaccine. And I will say that I do this for a living. I study this, I teach this for a living, and I lost my the other day in my family's WhatsApp chat group because one of my relatives who knows that I do this for a living shared the most awful conspiracy-laden video. And I thought, come on, there's all these hoaxes about COVID-19 in this video that you've sent. Surely you can tell that this is not accurate. This is terrible. But instead of doing what I'm going to teach you now, I just want to be human and put my hands up. That sometimes it's just very frustrating and you just think, can you stop spreading stuff that is so blatantly not true? But if we are able to get ourselves in the right frame of mind, take a deep breath, here's how I envision these conversations moving forward more successfully. So say the starting point is somebody saying, well, I don't want to vaccinate my kid. I heard that vaccines cause autism. I heard there's mercury in them. They're so toxic, and I'm just really worried about my kid. The key to that opening statement is the last part. I'm really worried about my kid. And that's why it's extremely important to listen and listen deeply, because what you are doing when someone is setting the ground in that way, sharing their beliefs and actions with you, is you are looking for even one nugget of consensus, one thing that the two of you believe together. So you may not believe that vaccines cause autism because they don't. You may not believe that vaccines are toxic, but you do share a belief that you are worried about that person's child, because why wouldn't you be? You want the kid to be healthy, and you're under the impression that the parent, guardian may not be wanting to vaccinate their child. So key at the beginning is actually you being quiet. For those of you who are healthcare workers, this is especially hard for you. And I say this not because I know you, but because I've studied the data that shows on average, and I wish I could do a poll here and ask you, but maybe I'll just put it out there as a question. On average, how long does a patient get to speak for before a doctor interrupts them? Just plow your own mind, think about how long you might think that is. It's 11 seconds. We don't let patients talk very long at all before we jump in with our facts. And what's key at the beginning actually is just listening. letting people talk and thinking, oh, okay, I just heard a thing that I agree with you on. I too am worried about your kid. So find common ground. The whole point of these conversations, right? The whole point of us taking a deep breath, taking a sip of our tea and being like, I'm gonna get into this challenging conversation, this thing that we both disagree on, is because we are hoping for an end result where there is consensus. To make sure that you reach that end result, please take the time at the beginning to listen to the person. You may have to listen to many frustrating things, but keep listening and listen deeply until you understand, okay, here's where I think you and I have shared ground. One way of doing this is to use a technique called motivational interviewing. Next slide, please. We could do a whole session on motivational interviewing. And if you're not familiar, I definitely encourage you to go read up on this. But in a nutshell, motivational interviewing has about 4 or 5 key steps. It's all about open-ended questions. It's all about deep listening. It's all about expressing empathy, which you can't do unless you're already listening and then mirroring back. Oh, okay, Mrs. Smith, so what I hear is you're really worried about your son, right? So you have to be able to listen deeply to do that kind of reflective feedback. Then what you're doing with motivational interviewing is you're finding the mismatch between that person's goals and what they're doing. So that person's goal is to protect their kid, make sure their kid is healthy and safe and has the best life possible. That's their goal. But their current behavior of saying, I don't want to vaccinate him, there's a discrepancy between that goal and that action. So you want to develop that discrepancy, help the person understand that those two are mismatched. You want to avoid argument. And the way that motivational interviewing talks about this is what it says is rolling with resistance. That means if you've gone from the listening stage to now offering some feedback, some reflective listening, and you're going to start launching into sharing some information, which you're going to do very carefully. But as soon as you start doing that, the parent is like this, like, oh, no, or they're just arguing with you. That's a cue to you that you need to do something differently. So roll with the resistance. You just ignited some resistance, stop, think about listening a bit more, and then consider switching up your tactics. Then what you want to do, kind of the final wrapping up part of motivational interviewing, is inspiring optimism in the person. You're saying, I believe that here's a discrepancy between what you believe and what you are doing, but I believe that in all humans, there is a capacity for us to have behavior changes. And the language of motivational interviewing is specific. They talk about supporting self-efficacy and optimism. So like I said, we could do a whole webinar just on this particular type of interviewing. There's some great articles out there that even give you summaries about motivational interviewing. So I definitely look into those. It's very useful in this context of discussing contentious and controversial issues where you and the person that you are speaking with are prone to just getting riled up and disagreeing and having that temptation of just pouring facts onto the fire and just fueling them. So next slide. So there's a lot on this slide, but if I go back to, we started with finding common ground, some consensus. We're doing that through listening. We're using the techniques of motivational interviewing. And then we want to be really careful that we don't lump everyone together. For example, you might see that this patient is saying, I don't want to vaccinate my kid. And immediately in your mind, you've built a picture of who this person is, what they ate for breakfast, where they do yoga, if they do yoga. You've made all these assumptions about them. That's not helpful. And it's actually inaccurate because even a group of people who share anti-vaccine sentiments are not a monolith. There is so much diversity within that group. And the danger is that by lumping everyone together, you assume a particular tactic is going to work. You're going to assume particular beliefs that are nurturing their action of not vaccinating themselves or their kid. And to not lump people together, you have to see them for the individual that they are. And that, again, comes back to listening and building empathy, finding, wait, what is it really at the heart of this person's action? Why did they come here? Why are they choosing to not get vaccinated or vaccinate their kid? Next comes getting comfortable with uncertainty. I talked a little bit about this last week in the context of science journalism. I said to you that when I teach science journalists about how to communicate about an evolving situation like a pandemic, that there's a temptation to try and build a lot of certainty where actually there isn't a ton. Things are changing all the time. We're learning about new mutations. We're learning about new issues. We're learning about different kinds of transmission. Get comfortable with the uncertainty. It comes back to that credibility issue, that people are more receptive to your information if you're saying the truth is, we don't entirely understand this. The truth is, things are changing quickly. We're keeping an eye on this, but here's what we know now. So what might happen during a conversation one-on-one with somebody who's choosing not to vaccinate their children is that they might bring up a lot of the uncertainty in science. And that's okay. I do not think that we need to run away from that. However, something that's useful is poking into the uncertainty in their arguments. Kind of a little tit for tat. You're not doing it in an aggressive way. You're saying, sure, science is never like completely 100%. There is always uncertainty in science, but here's where there's also uncertainty in your beliefs. Here's where there's uncertainty in the data that you're bringing to me. What you can then do is, from that starting point, emphasize scientific consensus. You can say, yes, that is true that no study is 100% accurate or statistically significant, for example. There's always margins of error and uncertainty. However, I can tell you there is scientific consensus around this. And there's even evidence actually that bringing an anecdote at this point can be useful, and saying, if you ask 100 doctors, 99 or even 100 of them will vaccinate their children. Or if you ask this many doctors about their understanding of the studies on vaccines, there is scientific consensus that vaccines are safe, that children should proceed with a vaccination schedule. So you're going from uncertainty, you're reaching a place of consensus. Key to all of this is that you don't follow my steps in a 1, 2, 3, 4, must follow the same steps for every single person. Because what's key is to listen, to observe, to say a thing, see how the person registers it. What was their reaction? Does that mean you need to switch gears? Do you need to tailor? Really think about the person in front of you. And that means listening, having reflective statements, and continuing to listen. Like I said, I started off this portion of the webinar by saying that I lost my call in a WhatsApp group the other day, because I was just like wanting to tear my hair out that, hey, I am your relative who studies this and teaches this, and you're even sharing this awful conspiracy theory video with me. So it can be frustrating, but my reaction, where I just got really annoyed and kind of like had a hissy fit in the WhatsApp group, didn't do anything constructive. The person who shared it went quiet, the conversation got derailed. I did nothing useful in that exchange. I had to go back and make amends and say, look, this is why, we don't want to share information like this. So it's challenging. It does require tailored approaches for the particular individual or group or the context, the country you're in, the political climate. But these, I think, are some useful steps and useful things to keep in mind when broaching these challenging conversations. So we have scheduled some time now for questions. If you have questions about this before Rob continues with the next part of the webinar.
I've been answering some questions online as they've been coming. So if folks go to the Q&A, you'll see a bit of a back and forth there. Some really great questions, by the way, so thank you.
Any questions relevant to the challenging conversations? Or Rob, did anything stick out for you that I said?
Sorry. Yeah, it is so, I was sort of listening to that with a lot of admiration, because it is really, really difficult. That first piece of listening, I mean, I live and breathe watching this, if you will, because as I think I mentioned in the last session, my wife is a family therapist. And so she just does this intuitively and instinctively. And I keep thinking that I know how to do this stuff. And I just, one conversation after another, I'm like, oh no, wait. The thing I think that you were mentioning is, I don't know where let me ask you actually. One of the things that I watch my wife do as a therapist is, and that she emphasizes to me, is, you might expect between husband and wife, is validation, 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 right? Before, that part of that listening piece is to say, yeah, absolutely, this must be a really scary thing for you to see your 6-month-old kid get this needle in their arm with a bunch of chemicals that you don't understand. That must be really scary. Is that part of the dynamic for you, or does that start to take it too far down a road that is, gets off the agenda that you need to be on?
So for me, it's that consensus point, maybe not about the scariness of chemicals, but yes, you are worried. I hear you. You want to be a great parent. You want to make the right decisions. You want to do your due diligence. I am with you on that. And it's building on that shared consensus that collectively we want to come up with the best possible decision for little Mohammed, or the child in question. I think that part is key, and it's easy to skip through that almost because there's just an assumption that of course we all care about the child in the room, that's why we're here, but don't run past that point. In fact, use that shared common ground as your anchor through the whole conversation.
It must be really hard when you're a physician and you're getting paid, as I imagine that you do, as people do up here, people do in different systems, fee for service, and you need to move through, and you have 15 patients before noon, and you have to move through. Being present with patient number 11, so present that you can hear that little moment, that must be hard. How do you stay present, like at 3 p.m. on a long day?
Well, you don't always, right? Because you're human. And I think you just kind of acknowledge that you're not always going to be great at this, that sometimes these conversations feel impossible. Maybe it's going to require more than one conversation. But I think statements of empathy are always really important, and making sure that the conversation is one where you haven't closed off the communication. Because to me, almost the worst case scenario isn't just that the person leaves and refuses to vaccinate their kid, but that they'll never come back to you and never continue that conversation, because then you've just completely killed all, back and forth. But yeah, it's hard. And that's why I shared that example of me doing everything wrong, not doing everything that I teach not to do, because, I was just really frustrated.
There's a question here from Jeff Durso. I don't know if you want to jump in on that. That one is for you. You see it there?
In the Q&A?
Yep.
So Jeff is asking, do you recommend defining a threshold of patience in having these difficult conversations, either professionally or personally? I'm curious about defining a point of diminishing returns. If we suspect, for example, bad faith argumentation is prolonging our patient engagement rather than good faith attempt at mutual consensus understanding. Gosh, I hope that there's less of that, Jeff, than there is just a concerned, confused, worried, deluged parent. I think that listening and deep listening is a good skill again here, because I think that's where you might ascertain, okay, this person is kind of wasting my time in some ways. They are trolling. I don't think this conversation is going to go in any way in an effective, successful direction. I've had less of those encounters, I think. Although, getting trolled on the internet, you definitely have people who are just stoking dissent or just asking you questions where you're having to prove the evidence over and over again. I don't know about defining a particular threshold. I think that comes down to the individual practitioner, their particular patient population, the political climate at the time, and also because, say, even if we did set some kind of threshold, maybe that goes out the window when there's a pandemic. Maybe it goes out the window when there's an election year, for example, or maybe it's at least shifted. So I think these kinds of thresholds, these kind of metrics we have in our head are quite personal and quite context-based.
There's a question here from Faizan Ahmad Razaki, and it looks like he might be writing us from Pakistan, about, and I'll just read it. How does one manage such information that can cause panic and results in a shortage of certain drugs from pharmacies just based on website information? So we're talking here about the use of dexamethasone. Is that the right way to pronounce it? I only read these things. I don't actually ever use
No,
them.
that's right. But also Faizan's question immediately before I read the dexamethasone bit made me think about the entire situation with hydroxychloroquine,
Right.
where you had the US president
Yeah.
touting it as a miracle drug, and you had people possibly die as a direct result of that, because there was at least one couple I saw where the husband and wife took a form of hydroxychloroquine that was in their home, formulated as a cleaning agent for fish tanks. But what they did was consume it. And they said, at least to reporters, that they did that because of what the president said. They both ended up in the ICU. The husband died. The wife was very sick. And also what we saw was people who take hydroxychloroquine for reasons where it's proven to work. They have lupus, they have some kinds of arthritis. We're saying, hey, this is a medicine that I rely on, and suddenly I can't get it because people are stockpiling it. And sadly, here in the US, I even heard stories of physicians stockpiling hydroxychloroquine and chloroquine with some kind of belief that it might be some cure for COVID-19, which shows how far reaching the misinformation and disinformation can be, that many of us are vulnerable even when we think we are not. This is where you see the weaponization of that term fake news or fading New York Times come in, because that's the perfect moment for the press to come in and say, hey, everyone, the president might be saying this, but look at the evidence. The evidence is not there to support these drugs as treatments for this disease. However, by that point, the highest office in the land, and you see similar sentiments in other countries, has so chipped away at public trust in journalism that any dissent against the president's comments are just read as, the press hates me. Of course they are saying this. They don't. There was even allegations that nobody wanted a cure for COVID-19, and that's why there was accurate information about there's no evidence to show that it works. So that's why I'm really careful, again, to not use that term fake news to try and empower good journalism as much as possible, because that's when it comes in useful.
I want to, there's a really, God, the questions here are excellent. There's one from Mike Sanchez, and sort of a related but different one from Ruben Kali, or Kai, I don't know if I'm pronouncing your name correctly, Ruben. Mike's question, which I think is sort of the elephant in the room, is what point does it become necessary to say that misinformation would cause public harm, such as the pandemic video? How do you convey that information can hurt them or others? 8.6 million people saw that video and now have Dr. Mikovits as their champion of their preconceived notions. I don't know that specific video, but I have a couple of thoughts of what do you do when there is effectively a tsunami heading your way, right? And you are the lifeguard on top of, one lifeguard station on one part of the beach. My quick thoughts are two. One is that I think we have to just accept, whatever our own scope of influence is. To begin with, right? No single physician or nurse or public health person can save the entire planet. I've taught enough folks who place themselves in those situations and then beat themselves up at night and can't go to sleep. And it can actually become I've seen this actually with some MSF doctors I've worked with, it can become a real issue and can become sufficiently preoccupying that it's sort of dangerous. So I think that managing and accepting the scope of influence that you actually have, which is probably your clinic and your community, is a good starting point. Not feeling that you personally have to save, 8.6 million people. The second, though, is that everyone belongs to organizations, right? You belong to the AMA or your medical association in your country, your state medical association, your alumni group from your medical school or your nursing school. You belong to your nursing college, whatever it may be. And that may be a place where you can start to get more leverage, where you can point out the specific risk here, present it with some actual data if you have it, underscore, and this is actually where some of those journalism skills are useful, underscore the significance, the impact, how surprising this was to you, and the course of action that this particular group, this alumni group, whatever it is, can take. And maybe, that's where you actually start a bit of a movement that goes in the opposite direction. I think that a lot of this, though, comes down to that fear question that Sunil raised early. Do you want to stand out in front of the tsunami when it comes? And I think that is a personal conversation for everyone to have with themselves. It is not easy. Again, I'm speaking from the relatively luxury of A, not being a health professional, and B, being in a country that doesn't have this level of sort of violent public discussion. But I think it's an ethical question. And I think that everyone on their own conscience will wrestle with the ethical question of how far you want to step into it. I would urge you, as best as I can, to not be afraid. Ruben has a question about working with I've been working with really poor people trying to inform them about COVID, but they really believe the misinformation that is circulating, and they grow in this environment where the misinformation is always present. How can I make them get the best information if they really can't have access to it? And how can I make them really believe if the misinformation is always present? My one thought that I'd offer here is to, and you may already work in this environment, I found sometimes that physicians, in particular among healthcare professionals, sort of feel that they are, working alone. That when ethical issues come up, they're sort of like on their own, inventing or rediscovering philosophical frameworks for utilitarianism and so on, whereas other people have been doing this work for a long time. In a community setting, I would suggest that there are other people probably who know the dynamics of the community, the physiology of the community, if you will, know how information is transmitted. They're probably not the folks who are sitting in your clinic. They may be social workers. They may be, I know in some Latin America or Latinx communities in the United States, that might be the church, right? Or it might be the minister, and the same with other communities. So if you can reach out to the folks who know the dynamics of that community and say, where can we actually interrupt this information flow and redirect it in a way that, even if it's not a medical or a health setting, that would be one suggestion I have. You don't need to solve this whole thing alone, in other words, in your own community. I think Seema's spent a lot in those settings than I have, so I'll pass over to you. And, yeah.
This is a great question, Ruben. Thank you for asking, because it also points to there being different reasons for misinformation spreading in different contexts, and also the idea that some of us are more vulnerable to misinfodemics. So I would add to what Rob said, in that, again, it comes back to listening and empathy and understanding the historical context for misinformation or disinformation spreading in that particular community. So if you joined last week, I think I talked briefly about the Tuskegee study of untreated syphilis in a Negro male that happened here in the US. Up until the early 1970s, this was an awful experiment where poor Black men, mostly sharecroppers in Tuskegee, who had syphilis, were lied to, told they had bad blood, and not given penicillin, even once penicillin had been discovered to be a cure for syphilis. What does that have to do with anything now? It has everything to do with the spread of misinformation and disinformation and vulnerabilities in those communities that were affected by that experiment. And we saw that pan out just a couple of years ago. I think 2015 it was. There was a really, really bad tuberculosis outbreak in that region. And there was a lot of consternation and frustration on the part of public health officials who said, we're trying to get this TB outbreak under control and no one's coming forward to get testing. Well, why would they? They lived an hour away from where the Tuskegee experiments happened only about, 40, 50 years ago, not that long ago. Some of those folks are still alive. They only got an apology from Clinton, not that long ago. There are ramifications, there is historical context to why some people buy into misinformation and disinformation. Understanding that can really help us protect them and undo some of their vulnerabilities. I think I also shared quickly the example last week of the biggest measles outbreak happening in Minnesota in the state's 30-year history. And that measles outbreak was largely concentrated in the Somali community in Minneapolis, because they had been specifically targeted by anti-vaccine groups. So again, instead of going in and saying, oh, so many Somalis in Minneapolis seem to be anti-vaxxers, how do we counter that? We really need to take a step back and see, how did this phenomenon occur over the last 10 to 15 years, because that's how long the anti-vaccine groups were targeting this community for, and think about how to counter that history.
Yeah, when the same thing, and then I think maybe at this point we'll jump on to the next piece, Seema. But another interesting example of that, as I understand it, was the latest measles outbreak in the Orthodox Jewish communities just north of New York, or New York City, where the interventions ultimately came not just directly from New York State Public Health, but New York State Public Health working with Orthodox physicians, Orthodox nurses and nurse educators, and some parts of the Orthodox rabbinate who got this and understood it and were able to transmit the information in a context that was comfortable for parents. So let's maybe jump into the next, if that's okay. And now I will switch the baton. I'll hand the baton on the Q&A over to Seema, and you can sort of keep an eye on it while we jump in. So this part, actually, we're changing. Sorry, I just want to, if you won't mind. I have multiple screens open, and I just want to make sure that I see everything I need to see. So thank you. Okay, so we're changing this to a slightly different, in fact, quite a different context at the moment. We've been speaking thus far today about the individual conversation, and we've been starting to get, because the individual is never just the individual, we've been starting to get from the individual to the community. I want to talk for about 10 minutes or so, 10 or 15 minutes now, about health advocacy as a political piece of work for health professionals and health scientists. And so this takes it out of the world of the individual and the sort of like apolitical community and into the question of how do you intervene when the state house, the provincial legislature, the federal government is now stuck in some huge debate over something having to do with health, and you see it all going sideways. Or you have a particular thing that you really need to get into the political conversation. How do you actually do that? For context, I think that this is particularly important now because health and public health have unfortunately become synonymous with one infectious disease, right? It's as if we don't have a CDC, we have a Center for COVID Control. We don't have a Secretary of Health, or you don't have a Secretary of Health, you have a Secretary of COVID. And up here, it's sort of the same thing. There are so many other equally, if not even more important social determinants of health, other chronic diseases, other infectious diseases, other things that where we have to keep the ball moving, racism as a public health issue and so on. So how do you actually put this stuff in? So I'm going to suggest, we're on the right slide here, that there are 4 steps that people tend to overlook, I think. A lot of folks who see an issue where they want to advocate jump right in with 2 feet or 12 feet or whatever, however you can be sort of ultra enthusiastic and sort of stand on the proverbial soapbox, which now is Twitter or Instagram, and just start preaching and advocating. That's not really advocating. That's trying to make noise. Good, but it's not going to actually move the ball. So I think that there are 4 things one has to think about, and we'll go through each of these. One is defining a specific ask, and we'll get into what that means, and who is specifically in charge. What is the relevant power here that has power over that specific ask? The second is looking at the context in which that decision maker, or as George W. Bush called it, that decider, will be making his, or their decision, and targeting an approach into them and around them so that they can make the decision comfortably. And that in turn drives to something that I think is key, and it's actually a little bit, well, in fact, not a little bit, is entirely consistent with what Seema was talking about listening carefully. This is also about building unlikely allies, building allies for your issue who are not really the folks that you'll be spending weekends with. You wouldn't normally go to a rally with them. You wouldn't normally be on the same Facebook group as them, but they are an important part of the context, the decision maker's context here. And finally, the currency of all of this, which we'll get to at the end, is called the B note, the briefing note. A very short thing that the decision maker, the decider, can read in the car on the way to the airport, when we all get to fly again. So if we go to the next slide then, Jayzona. Great. So let's start with defining your actual ask and locating the folks who are in charge of this. This is sort of, if you'll excuse me, if you already know this stuff, this is sort of basic civics. But it's, and I think it applies pretty much anywhere, at least in any democratic environment. It probably applies in a similar kind of way in authoritarian or semi-authoritarian environments, but I've never worked politically in one of those other than briefly in South Africa, and even there, not really. So I'm going to restrict this to democratic countries, but I think the same principles apply. The first question is, what do you actually need in order to move your file? And in order of increasing facility or simpleness, we'll start from the most difficult to the simplest. There are really only 4 things that you can ask for, but they represent everything. You can ask for a new law or an amendment to an existing law. That's probably the hardest single thing to get through. That depends on your system of government. In Canada, hold on a second. Okay, great. Sorry, I'm just looking at something. In Canada, that has to go through Parliament or legislature. In the States, it has to go through 2 completely separate houses of a legislature. It's hard. And if you ask for an amendment to a law, that is a can be a multi-year process. But that changes the law, and that's definitive. You could be simply saying, we don't need new laws, we just need money to fund this thing. You don't need a new law for it, you need a budget allocation, right? So you just need money. That's the second thing. Third might be that you need new regulation, right? There's a difference between regulations and laws. A lot of people don't get the difference, so I'll spell it out really quickly. Laws in and of themselves don't get executed. What gets executed are regulations that are, the law spells out what the goals are, and then they get broken down into regulations. Often it's not the case with criminal law, but with most laws, they get broken down into regulations, and the regulations are what's actually applied. If you want to change a regulation, you don't necessarily have to go all the way back to Congress or the State House or the provincial legislature or Parliament. You can go to the regulator and lobby to have the regulator change the regulation, or go to the part of the executive branch and lobby them to change the regulation. So regulations are a little easier. And then there's operations, just protocols. Like, we need to change the way we do this thing. One of the questions that came up was about, which I answered in the text. I didn't answer to everyone, but my answer is just in the text, was from one of your colleagues who was asking about intervening in opioid addictions, and that it is easier clinically to intervene upstream at the early stages than downstream once the addiction is really taken root. I don't know if I'm getting the science there, but that sounds to me like a change in operations and process rather than a change in law, budget, or regulation. So what do you actually need? And break it down. What do you actually need in order to make the change that you want? And then you have to ask number two, whose ambit is this in? Who has authority on that? First of all, what order of government? Is it local? Is it my city or my county? Is it my state or my province? Or département in France? Is it federal? Is it some other group? Maybe it's not even governmental. It may be an industry group. It may be a professional practice group. It may be that you're actually trying to lobby an organization to change. Maybe they actually have the influence on the specific thing, particularly with operations or regulations. These things are often run not by government, but by the industry itself. So once you've done those two, and then within those, what part, right? So if I do figure, okay, this is a state law that needs to change, or I need money from the state in order to do a clean water thing in my part of Michigan, I need money from the state to do this. Then what part of the state government am I actually asking for? What committees in the State House and what part of the executive branch will be on top of this? This is already overwhelming and complicated, which is why the best single piece of advice that I can offer here is to get help. If you're operating individually as an advocate, if you're trying to move a file individually, then join an organization, right? Because most organizations, large organizations, that have any kind of government relations or public policy dimension to what they do, will have part of the organization that actually does this. They're lobbyists, right? If you run your own organization, and I know that there are some folks on here who are running their own foundations, their own organizations, their own healthcare organizations, whatever it may be, then consider having on your board someone who has government relations experience that is relevant. If you are mostly regulated by the state, if you're mostly regulated by the federal government, get someone with government relations experience like that on your board who can give you advice. It is because otherwise it's too complicated. I've worked in politics in Canada at a very senior level, and I couldn't provide this advice right now on my own. I would need someone else's advice on how to navigate this because it changes every week depending on the personalities. But I think that the key thing that a lobbyist will ask you, and I should also be clear about one other thing, what a lobbyist is in this context. A lobbyist is not someone who hangs out in dark corners outside of the legislature, meets a congressman or congresswoman in a parking lot and hands them cash. That's not a lobbyist. A lobbyist is someone who is connected into the way that power is working in the relevant part of the government that you need to influence, who knows who the personalities are, knows what they were talking about last week in their committee, knows what their priorities are. Yes, I know they talked about this in the last election, and this is one of their platform planks, and they went door to door, but I can promise you they haven't been talking about this for a year because they're on to this other thing. Or that person loves your thing, but she's totally ineffective and she's not connected to anyone else, and even the governor won't speak to her. So you need to go to that person. That's what a lobbyist actually is. They provide you with intel, right? They're the pathologists, the diagnosticians of the political context. So get them on your side. I'm just going to jump through. If we sort of keep going into the next slide here, and then we'll sort of pack in questions. This one looks really complicated. It's actually not. The real point here is to ask yourself the first question right at the top, which is that ask, once you've defined it, and once you know who's in charge of the thing of making that decision, really you have a first order question, which is this political, like, is this public and controversial? Is this going to blow up? Am I going to read about this on the front page of my local paper, or, or homepage, I see it from my local paper, or the Times or the Post or the Guardian or whatever? Or is this so technical, so in the weeds, so inside baseball that, no one will care unless you're in this field already? If it is the latter, if it's highly technical, then I think you can actually, once you've identified exactly what you need and you've identified the folks who make those decisions, you can actually just present them with evidence. And you can have a real evidence-based conversation. You're all colleagues. You have the evidence. You can try to understand why, you'll face one of two situations. Either the technical leads support it and get it, but they just haven't seen the evidence, or they haven't had the time, or this hasn't felt like a priority to them. I've been on 15 other files. I didn't really realize we need to move on this. Okay. Or they see the evidence, they get the evidence, but they're still opposed to it. And then do that thing that Seema was just talking about. This is one of the places where Seema's meaningful, difficult conversations piece works in this context as well. Understand why if they are professionals like you, they understand the evidence as you do. They've now seen the evidence. They're still opposed. Stop long enough to understand why, and look for that one common thing. But the key is to give them evidence in a context that makes sense to them. That's pretty straightforward. The more complicated piece is if it is likely to be political. And in a highly polarized environment, even very technical things can start to become really political because they represent something bigger. There were riots, we now forget all news that happened before COVID, but you might remember that in the fall, there were riots in Chile. And those riots, I don't know if folks are joining us from Chile or Southern South America, but those riots were about a tiny increase in bus fare, right? Because that represented something huge in a highly polarized context. If you think, or if someone else, some advisor of yours who may be on your board says, you know what, you think this is inside baseball, but I can see this thing blowing up, then you have a more complicated political context in which to advocate. And then you sort of have, you can go down either the far left or the far right side. That's really a function of those questions we had in the first slide of who's in charge of this specific ask. I need money, who's going to be making the decision? I need a new law or an amendment, who's going to be making that decision? If they are supportive, let's actually start with if they're opposed. If they're unlikely to be a friend of yours, just prima facie, right off the top, they're not going to be listening to you. You're coming, they're conservative, you're liberal, or you're conservative and they're liberal. And you're coming at them and they see you a mile away. Before you approach them, get a sense of who they listen to, who influences them, where did they get their cues, what organizations give them their cues on a whole range, share their political values, and find an organization that actually has credibility with them and that may, interestingly, share your values on this particular topic. And it may well be that they are not active on your file. They're not active in the issue that you are on. They might be active on a completely different issue. But it so happens that on this thing, if you look at the sort of periphery of your issue and the peripheries of theirs, there's some kind of overlap. This thing, you're all about cracking down on illegal immigration, right? I can't share your opinion on that one. But I know that one of the reasons that you feel the way you do is that you worry about crime. You make an inaccurate connection between crime and illegal immigration. I'm not going to argue with you on that. I don't agree, but I'm not going to argue. But you care about crime. And you care about safety in your community. I care about safety in the community. Opioids are a public safety issue. We have an overlap here. Let's not talk about illegal immigration. Let's not talk about safe drug injection sites. Let's just talk about safe communities. We may have an overlap, whatever it may be. My favorite example actually locally here is when a large bike advocacy group made common cause with the Canadian Automobile Association around advocating for bike lanes in Toronto, with a government that was a very Trump-like anti-cycling kind of government, not that Trump is anti-cycling, I have no idea. They made common cause because the Automobile Association wants safe roads. The bike guys want safe roads. The premier here was not going to call the cyclists for advice, but he was going to call the Automobile Association because he loves cars and commuters. So find the vector in, find an unlikely ally. The same is true even if you think that the political power is on your side. If they're on your side, you will probably come across someone who says, look, I love you, my folks love you, my husband, wife, partner loves you, we all love you. Here's the problem. If I do this, the first call I'm going to get is an angry, screaming call from those folks over there. And I have a primary or I have an election in 4 months, and I can't afford that. So I'm in a bind, man. I've already fought for you 3 times. I can't afford this. If that's the situation you're facing, then do exactly the same thing. Protect their flank. Find the organizations that will be attacking them, someone from that world. It may not be the specific organization attacking them on this file, but it'll be someone who's a fellow traveler of theirs, who has credibility in that world. Find them, listen to them, try to make common cause with them. The key on both of these is to try to create a coalition, not just of folks who are like-minded, but what I call a coalition of unlikely allies who are going to surprise the system. When you go to them and say, really, you spoke to them? How do they even answer the phone? Well, because it turns out we and they both care a lot about some dimensions of the environment. They're hunters, I'm a conservationist, I'm Greenpeace, but we both care about keeping wetlands. They care about it because they want to kill ducks. I care about it because it's an important part of the ecosystem. I don't care why they care about it. I just know that we're on the same page about this specific thing. And that's why the specific thing is key. I don't need to save the planet right now in this conversation with you, Mayor. All I need to do is save the wetland on the outside of town. That's not a health example, but it gives you a bit of an idea. Maybe if we go now to the last several new questions. Okay. This is really just making the same point very quickly, that unlikely allies will unlock a political stalemate. So identify the politicians who have power on the specific ask, right? I'm not asking to save all wetlands. I'm not asking to save all, to promote all vaccines. I'm asking for a specific allocation for a measles campaign that has to happen by October, or we're going to lose this batch of kids. So what is your ask? Which politicians have power on that? To whom do they listen, or who are they afraid of? And then scan those influencers or those nemesis beyond groups that are active on your issue and find some kind of common ground. Last point, I'll just go, because I think I just have a minute or so left. Sorry, next slide. Thank you. The currency of a pitch, we were talking about this last week, of working with journalists, is a pitch, right? A story idea, 100 words. I gave you the sort of basic questions to ask. The currency in political advocacy is the briefing note, or the B note. I also play guitar, so B note means something a little different to me, but it's a very brief briefing note. The reading time, 3 minutes. This is not a white paper. The person 4 layers down, who's the big policy person who just finished their PhD at, on the subject, they'll read the 50-page white paper. The actual decision maker, who's a former used car saleswoman or insurance salesman, will not read a 50-page decision paper on a complex issue of health. But she or he will read or they will read a 3-minute briefing note on the way to the airport. And it should have these 4 pieces in it. Your specific ask, whom you represent, what's at stake. This is the same thing as we had in the last, in the pitch document before. Why is this really important to your constituents? And now some context here, right? Here's some different options that you'll consider. And very critically, here's the environment, okay? Here are the folks who support me. Here are the folks who are against this. I'm not gonna hide this from you. And here's the folks we've reached out to, okay? And here's why, that they're in the tent. You might get one of these B notes from them too. So I'll stop there. Thanks for giving me the extra time. I see there are a bunch of questions.
I've been looking at them closely, Rob. Before I present some of the most relevant ones to you to answer, Rob, I was just thinking of how applicable so many of the things we are saying are to one-on-one conversations about someone's personal life and personal actions, and then on a much broader scale, whether you're communicating with politicians who are making big decisions, or you're communicating with the press. And it actually was making me think back to high school physics, when you learn an equation to understand the movement of an atom, and then you learn it's the exact same equation to understand the movement of a whole planet. So like whether it's micro or macro, all of these things are very much connected.
Yep.
And I want to ask you this great question
Yep.
from Espen, who says, do you think it's up to the scientist or the healthcare worker to advance their findings to that point of arguing the value to the relevant power, or to lobby that their findings be taken seriously, which will be a good segue into our kind of final thoughts. But yeah, what do you think about that?
I think that it's a very personal decision. I think it's a very personal decision. And I mean, look, I'll just sort of speak from some personal experience. And I think my dad at some point will be watching this. So if you're watching this, Dad, big salute to Dad. My dad he's now retired from his scientific career, but as an endocrinologist, he was one of the folks who really changed the game in understanding of metabolic syndrome, the precursors for diabetes, the connection between diabetes and atherosclerosis, and all of that kind of thing. So this has huge public policy implications, right? And to some degree, I remember as a kid, he would go on the morning shows, and I remember we used to get these great sort of mugs from Canada AM, which are our equivalent of Good Morning America, and he'd do that to some degree. And at one point, as I became more politically active as a kid, I would, like some jerky teenager, say, Dad, you should just get out there, go up to the First Nations communities, or Native communities, we used to call them then, and speak to them. And I think my dad was a scientist, and of a generation, particularly of scientists, who felt, you know what? My job is in the lab. I focus on the science. I do speak more broadly, and I do advocate more broadly, particularly with my patients and in those settings, but that's not my skill. And I think that is not just because of my dad, I think it's a totally honorable perspective. Not everyone wants to do this. Not everyone feels it's their job to do this. I will say that I think that the context has changed, the climate has changed. I think that an earlier generation of scientists were discouraged from doing this. And told they shouldn't. And I think an earlier generation of physicians was actually discouraged from doing this, and told this is not really your business unless you're the Surgeon General. I think the expectations have changed, and I think there are a lot of different kinds of physicians who are coming in to the field, and different scientists who feel that they want to advocate. So I would ultimately say it's a personal decision. It's also an ethical decision. If you're seeing something and it's really roiling you up, and the public conversation needs to change, if you're not the person to do it, get someone who can help and let them do it. Moses was called on by God. I'll say this because I'm Jewish and I believe this stuff. Moses was called on by God to go speak to Pharaoh. Moses said to God, I have a speech impediment. I can't do it. And God said, okay, your brother Aaron is actually pretty good at this stuff. Bring him along. Find an Aaron. If you feel you need to do it, and if you feel it's an ethical imperative to do it.
I like that response. And also I'll be expanding more on that in my next presentation, which is all about building a credible role. So let's have a look. There's another question. Oh, so people were also sharing examples of issues that they believe might be being neglected because of the pandemic. So Sunil also chimed in and said an example of what Bob is talking about is in Mumbai is overcrowding in the slums of Mumbai and the issue of healthcare. And he also mentioned tuberculosis, drug resistance, TB, and overcrowding is an issue long neglected, is something that would find many allies. So hygiene, toilets in these slums are needed. And for ages, we've been talking of these breeding grounds for disease, but how that's been a long-standing issue, right? TB is nothing new. It competes almost for the same funding dollars, the same pots as suddenly COVID-19 comes along. And it becomes the focus. And we're really good or really bad in public health at like being hyper-focused on one thing at the expense of everything else. How do you shift that focus?
I am so glad that you raised TB as an example, because to me, TB represents the cost of tunnel vision within the health. I mean, I'll allow myself to say that I'm part of the health professional community. Within the health professional community, there's this hyper focus. I've heard two examples at the clinical level, the individual level, the same thing in Toronto, from physicians that I taught. An internist who's now attached to the Emerge team at St. Mike's. They had a TB patient present all the classic symptoms. They actually sort of figured it's probably TB, but they knew they had to do a lumbar puncture. And then this was early days of COVID, and they didn't have enough PPE. So they're like, we'll just sort of park her in the emergency room for 40 minutes. My son, who's working as a COVID screener at another major teaching hospital, TB patient brought in, left in the reception area of the cancer center, right? And these are just, when you put all this stuff together, it represents this tunnel vision. So where does the advocacy have to start to happen? In our own profession. So TB, absolutely, right? This is, I would say, whether it's TB or mental illness or whatever the other things are, I think that, I forget the initial question, but I think that one of the pieces of advocacy that we have to do here is within the profession itself to say, remember, we are not COVID doctors and nurses. We are doctors and nurses. We are not COVID public health professionals. We are public health professionals. There is a much bigger piece here. And that, by the way, also allows you, when you broaden the scope of the conversation, you do exactly what you were talking about, Seema. You actually allow for there to be more potential common ground with the person who's meeting you, right? Why am I pissed off about having to wear a mask? Because it's why do I insist on reopening? That's a better example. Why do I insist on reopening? Because I have to work. It's not just about freedom in the first, second, third, fourth, 15th Amendments. It's like, I have to work. Yes, absolutely. I'm a public health professional. I'm a physician. I'm a nurse. Work is actually a determinant of health. You are right. You have to work. Let's go from there.
Yeah.
Let's go from there. That's our area of common ground.
Yeah,
Yeah,
Jeff,
absolutely.
yeah, Jeff makes a really good point in the chat about the consequences of that hyper focus. And I will say that the whole idea of AIDS exceptionalism, people might be familiar with this idea that this new pandemic came along in the 80s, and then money went to focusing specifically on HIV/AIDS to the point that in some settings you'd have an HIV clinic, which was great, but kids still dying of diarrheal diseases, people still dying from TB and malaria. And so you need that kind of integrated horizontal model of funding. Jeff's point is, he starts by saying, I've admired the discussion of overlooked health issues that many healthcare professionals and journalists have highlighted during COVID. In a vacuum, mandatory quarantine for a year would likely destroy COVID, but at what other health costs, which is exactly what we're talking about. And Jeff lists mental health, depression, anxiety, all of which we've seen. So I think that's a really useful point. There's a question from Tushar. Tushar says, in some countries, government control media. They are hiding total number of cases and deaths of COVID-19 for their political careers. So how would you find out the exact number of cases in that country? I think that's one issue, but Robert also ties into what you just talked about, which is that's a kind of different context within which to be doing that kind of advocacy. It makes me straight away think of journalists like Maria Ressa, so many investigative reporters around the world who are in situations like that, where the government controls the media and they are so dogged in their determination to get the news to the public. Before I let you answer, Rob, I will say another example in the US. Okay, the government doesn't control the media to the same extent, but the government here has been fudging data.
Yeah.
When we were looking at the numbers of tests being done, we were told we were looking at just the number of PCR tests looking for virus in samples. And it turned out that they had lumped together PCR testing with antibody testing. So there was journalists who found that there was that discrepancy. So it's applicable in many different contexts, in many different places. But Rob, in your opinion, how do you deal with that kind of context where the government controls the media?
Well, I think that there are two ways two dimensions on which I would address it. And the first is, and I have to do this again, very humbly, very circumspectly, because I have the luxury of not living in a context like that. I briefly experienced one when I was a reporter in South Africa for a South African news organization back in the 90s, but I really don't know what it is to operate in an environment like that. But I've spoken to a lot of reporters who do operate in environments like that. So I think the first thing is, I don't think doctors are used to working in an environment like that. This is something that reporters are used to. Reporters pick jobs to do that. I think most doctors didn't think that they'd be getting into this business when they became doctors. So part of it is to acknowledge that you may be in that business. And I would start by saying safety first, right, for everything, right? I don't think people should place themselves. It's easy for me to say. I think it's a very difficult. Let me put it this way. I don't know what people should do about their own safety. I think it's a very difficult personal calculus. And I think that the reality is that public health activists are now getting targeted as anti-government activists. Maria Ressa, who's a journalist for the founder of Rappler in the Philippines, is a great example of that. In terms of actually working to get the information out, assuming that one can take care of one's safety or one's made a decision to take the risk in order to do that work, I think one of the nice things about the health and scientific community are that it is global, right? So you can actually work with people outside who may be monitoring what's going on in your country, maybe through surrogate data. It may be that travelers from your country into other jurisdictions have been tested, and there are data from, if there are direct flights from your country to, something just over the border and people showing up there testing positive, maybe that's a surrogate datum. Maybe WHO has data. Maybe there are investigative journalists who, just by the shoe leather of calling around, which is how it works in Ontario, calling the public health units and knowing how to have conversations confidentially with people, can generate this stuff. And you can work quietly as a resource to them to help them understand the data that they're getting. So there are other ways, right? Coloring the circle from the outside in. We're raising questions saying, it's totally inconsistent. The government is saying this, but this is what we're seeing in the clinic. So something is missing here, right? Yemen has 25% fatality rate. The rest of the world has a 0.2% fatality rate. So something's going wrong with the testing, right? So signaling that kind of, apart from the fact that their healthcare system is, wrecked. Signaling that kind of stuff may be a way to break it open. Doing it with allies who have the investigative skills may be a way to break it open, and doing it with allies outside of the country. Chinese physicians, I think, were under a great deal of pressure to, write their case reports in certain kinds of ways, judging from what I'd heard from clinicians here who were reading them early in February. But one can have, if one has the channels, conversations, more frank conversations with colleagues outside of the country and say, this is what I'm actually seeing. I can't put it in my words, but if you do it, it'll be heard.
Yeah, I like that analogy of coloring the circle from the outside in. And also it's what happened here when in the US, data about the number of positive tests, for example, earlier in the pandemic went missing off the CDC website, which was very troubling. There were journalists at The Atlantic, but also a ton of local newspapers that were just picking up the phone and calling every single state's health department, figuring out one state was reporting differently to another state, but still, what could we learn by gathering that data? Again, very different context. I'm talking about the US, but I'm thinking about the different challenges that the public and the press face in different countries, just ways around it.
Yeah. And I think being sensitive, to those folks who are listening from contexts where the political level is going to take personal offense at this stuff, I think frankly being sensitive to that, there is at a certain level, there's no need to call out the president or the governor or the military or whoever it may be, or the minister, and just say, you personally are killing people. Yeah, we all want to say it, but you just say, look, these data seem sort of weird. I don't know. I'm mystified. I'm a doctor. I don't get it. Yeah. I've seen tons of people in my hospital, and yet the data are telling me something else. Maybe someone can help. I'm being naive here, because the physician who did that in China, ultimately died, but he was also really harassed very intensely by the state. So I'm being naive, but I think that there are options. Certainly tapping into the networks, both internally of other folks who are in a political position to take the risk, and externally into colleagues. Anyway, being the same points, blah, blah, blah.
And Mahmoud in Egypt is sharing, this same kind of problem, a discrepancy between what's recorded in terms of the average number of cases a day versus what the Egyptian government is releasing. So it's certainly a problem in many parts of the world.
Here's the other thing that might be interesting, and I'll say this advisedly, and I know that this is difficult in different places. So back in the days when China was denying that there was such a thing as air pollution in Beijing, but everyone knew it, the US Embassy put monitors on the embassy building in Beijing and just started tweeting out the ppms every day. They just posted them. Here's the air quality index. We use the same standard that we would use in the United States. We're using it here. We just put the data out, and they start to accumulate data. So it raises a possibility that, you can find, the United States won't be a safe place. I'm sorry to say this isn't a safe place to share this information with, but Germany might be, and Canada might be, and Sweden and Norway might be. Norway probably more than Sweden. So if you're in a country that has those embassies and they have folks who are interested, you might quietly make a call to them and say, look, if you want a real picture of what's going on here, I'll tell you. That then goes into those systems, and particularly if they're connected into the United Nations or the WHO, and they're highly credible countries that have sort of figured some of this stuff out, like South Korea and Germany, they have an interest in, or regional or sort of regional powers that may be a little bit, more interested in what's going on in that region, they may have an interest in sharing that stuff. This is risky stuff, so I want to be very careful about suggesting that people take their lives into their hands, drop this stuff off, but these are different kinds of options to think about.
And to be honest, that's a perfect segue into what I'm going to talk about for the next 15 minutes or so, which is how you do this. How do you build a compelling and credible public role? Because that last part of that sentence, that public role, will vary massively depending on who you are, what your professional responsibilities are, what your desire is to engage with this, where you live, how safe it is to potentially be a whistleblower or somebody writing about issues that governments would rather you didn't. So when I think about the role of the public intellectual, perhaps we can call it that, I think about this very much being on a spectrum. And so on the one side, I see people actually like some of my colleagues who did the fellowship in global journalism, Rob, at the same time that I did, who, as soon as we had finished our 8-9 month long program, went back to clinical practice and are still very much embedded in clinical practice. It's their 9 to 5 or more like their 9 to 9 every day. And what they do though, is they're keeping a close eye on their field. They're looking at what's being reported and what isn't, what information that they think needs to be shared. And what they might do with that is a monthly article. They might just be staying in touch with editors and saying, I'm going to pitch you something, and that might be once a week in the context of the pandemic. It might be once a month, it might be less. That's one end of the spectrum. I think of that as the practitioner who's very much still embedded in their field and doing little bits of journalism here and there. Perhaps you could replace the journalism with advocacy. On the other end of the spectrum, I think about my colleagues who also did the fellowship in global journalism at the Monk School and who, after completing the program, became full-time staff reporters embedded at the FT, for example. And so they had left their professional practice in another discipline, and now they were full-time reporting on their area of expertise. And then I think about every iteration in between. I think that when I graduated from the program, I landed right in the middle in some ways, because I had 2 jobs, each of them taking 50% of my time. So half of the week I lived as a staff writer in the newsroom of the Dallas Morning News, reporting on public health, reporting on Ebola and Zika, gun violence, all these public health issues. But the other half of the week I was teaching epidemiology at the University of Texas at Dallas. So because the next part of the webinar, after I've kind of talked through these roles, Rob and I are going to talk with you in a much more interactive fashion about what some of the risk might be, how you manage some of that risk. I think a lot of that depends also where on that spectrum you land. And in your responses earlier, Rob, you talked about there being, it's about your desire, it's about a very personal decision, it's an ethical decision. You were saying that in response to one of the questions. But I bring this up because I want you to know that it is a spectrum, that at any given time you might sit somewhere on that spectrum, and then that could change from time to time. So as I think about moving along that spectrum and how as a healthcare worker or a scientist you might engage the media, you might engage broad audiences, there's every iteration of that, including having your own podcast, blogging on Medium, so you're not working with an editor, you're not necessarily using the exact same pitching skills that we taught last week, but you are using them in a way that focuses your thoughts into an essay, into some kind of content that can engage people beyond your professional circles. Maybe it engages a lay audience, a much broader audience. There's also the possibility that you take those pitching skills from last week's workshop, which you can watch in the video, and you start pitching ideas to editors and reporters, but in 2 different ways. So one way that I envision this is that you are building relationships with reporters so that you are placing yourself as an expert source, somebody who is credible, somebody who is knowledgeable, and somebody who's going to help that reporter do a really good job, because you're going to tell them what they need to be reporting on that perhaps is being missed. Reporters love this. We need good sources. We're always looking for good sources. And I think this is something that you can do early on and proactively, where you take those pitching skills that we taught, but you're not saying, I will write the story. You're saying, here are some stories you might want to consider in the realm of chronic TB and homelessness. Here are some stories that are not being discussed around prison health. And here's where I can help you. I can be a source for you. I can find you other experts. There's ways that I might be able to have some of my patients, respecting all of HIPAA and all of confidentiality, but they might be able to share some stories with you. Reporters love it. What you are doing is a public service, because for the rest of us, you are bringing us those stories that are not otherwise being told. And that's because you're so deeply entrenched in that field, you know what's important and what needs to be discussed more. The other way of doing that is building relationships with editors where you are pitching the story yourself. So that's much more in the way I suppose we taught that skill set last Tuesday, which is you have an idea and here's how you might focus that idea into a pitch, having done research on the particular TV station or radio station or newspaper or magazine that you want to pitch to. Instead of being a source for a reporter, in this instance, you're going to be the person creating that content. Now, there are still different ways, even within that realm, of doing that. You might be writing an op-ed, or you might be doing what I do much more of, which is reporting the news in that field. So not an opinion piece, but a reported piece. And there are definitely hybrids of the two. We can do whole sessions, and I think because there's appetite, we might in the future do some CME sessions on everything from like the nitty-gritty of how to write an op-ed, how to structure a reported piece, how to go about and do the reporting. But for me, the early stages of all of that is relationship building. And if you remember something that I said last week, or I was saying that to me, all of journalism, all of writing is all about how do I make somebody care? I have this issue that I have dedicated my life to, or that I'm seeing my patient face. I think it's so important. I think it's being missed, it's neglected. How do I make you, the public, care about this? And to get to that point, how do I make a reporter or an editor care? So I think all of our skills come back to that key question. Rob, you can completely disagree with me if I'm kind of making that too simplistic, but to me, that's really the heart of it. And again, it's, you know, I talk about the micro and the macro communication, whether you're writing for a broad audience, you're doing a hit on CNN, you're going on the radio to talk about something, or you're sitting one-on-one in a room with a mother who's trying to figure out whether she should vaccinate her kids or not. It's still coming back to that question of how do I really make you care? I wanted to talk a little bit about just finding your happy spot, whether that is writing op-eds, whether it's writing reported pieces, whether it's doing that where you just publish yourself on your own blogging website, or you use Medium, or you are reaching out to reporters so you have an editor. I think some of that is finding what you're comfortable with and experimenting a little bit to find what your sweet spot is. Some of you I know registered for this because you're really interested in going fully into developing a podcast and you wanted some like early steps on how to do that. And others might be much more platform agnostic. I would say even tweeting and engaging on social media, if that's safe for you in terms of the political context of where you live and in terms of your professional responsibilities, tweeting and engaging with folks on social media is useful on a few different levels. One, I know we complain that social media makes us like distill everything into like very small nuggets, but there's some strength in that you kind of have to have cohesive thoughts that can be communicated succinctly. I love some of the Twitter threads that I read from experts from all sorts of academic disciplines that I don't know about, but they engage me in their work in a way that relates to me and makes sense to me. I think that can be a great starting point. Of course, there's also podcasting. Again, you can do that through more professional networks, or you just get some basic equipment and start yourself. Then there are ways of publishing that require bigger commitments. And I'm thinking about book publishing. I've written a few books. I have more books coming out. I love it. It's not something that I thought I would enjoy doing because it just seems so gnarly, so big and complicated, but it's actually really satisfying, I think, to get your teeth into a topic and report on it for months or years even, and condense that into this one volume that guides a reader through a story. I think there's scope there for us maybe to do more CMEs in the future about book publishing, but I would say that it all starts with, again, a pitch. It really does. For a nonfiction book, you are writing a proposal that's not that long. It has some information about you. It has a summary of what you want to cover in the book. It has maybe one sample chapter and a table of contents. And it has an overview of you and why you are the right person to write that book, which is completely what Rob was teaching last week when it comes to pitching an op-ed or a magazine article. It's all about why now, what's going to be the structure, and why should I be telling it? So I hope that me explaining that as a spectrum is a useful way of visualizing where you might go after you've completed these 2 webinars. And also just remembering that it's fluid at different times, after the pandemic is over, during the pandemic, you might sit somewhere different on that spectrum. So I'll leave it there. We'll have some questions. Then the next thing we're going to talk about is very much linked to this, which is how we might manage the risk of being very public in talking about our roles and in what we're seeing on the ground.
I've been answering questions along the way. There are a few.
Great. Some great questions.
Yeah. So are you looking at them too?
I'm looking in the Q&A.
Yeah. Yeah.
So Sunil's asking, one of the issues here is that of rate cards, for being an expert. Yes. I think this goes back to something I also mentioned last week when I was kind of peeling back the curtain on journalism. And I was saying, journalism has so much power to be our source of, here's what politicians are saying that is not accurate, here's what the scientists are saying that is accurate, here's what you need to know to stay safe. And then all of that can fall short if the sources that journalists are turning to are not really experts in the things that they're talking about. And unfortunately, in the context of a pandemic where it's so chaotic, it's such a huge crisis, and the information is literally changing. You know, there were 2 retractions, one from the Lancet, one from the New England Journal of Medicine, you know, in the space of hours. So much is changing that it creates space for there to be not so great sources, not such great experts, to kind of fill those gaps. And I do worry that early on we saw people that didn't really have good epidemiology chops being the ones that had the most, you know, biggest mouthpieces, you know, given a lot of the time and platforms of television. I don't know about rate cards, but I think Sunil's also saying if you pay up, you'll be treated as an expert. There are a lot of ethical issues there. As a journalist, my favorite sources, although it's a bit annoying at first, is the sources who are like, no, I can only speak to this like very niche thing. That's what I spent my life studying. And I'm like, oh, but can't you speak to this broader thing? But I trust those sources.
Yeah. There's a real tension there, right? And we say, I think I mentioned before, the word epidemiologist now is like this rubber word. Most people don't understand what it means. People talk about clinical epidemiologists as if they're experts in disease dynamics, when really a master's in clinepi means that you know how to do large studies and do clinical studies. You may also be an expert in disease dynamics, but they don't mean the same thing. There are virologists and molecular and microbiologists who present themselves as infectious disease specialists. And there are infectious disease specialists who work entirely in hospitals, who present themselves as if they know about community spread.
And a journalist has to make sense of all of those distinctions.
Right. And so I think one thing, it's incumbent on folks, particularly folks, you know, and I've seen this happen with some of my colleagues where people are, you know, now is their moment in the sunshine, right? Suddenly someone is calling them. No one has ever been interested in their work before. And so, yes, okay, I have a master's in clinepi, so I'll present myself as an epidemiologist and I can answer some basic questions. I would say that it's really incumbent on people not to do that and to stick in your lane. And to resist this temptation that journalists will be presenting to you saying, yeah, I know, but I don't get the broader context, right? So can you give me a broader context? There's a tension here because people are so much in their lane that they can't see the bigger picture. That's not helpful to the journalist. But if you start to freelance outside of your thing, and I don't mean freelance as a reporter, but if you start to just like roam all over the place, before long you find yourself commenting on environmental health issues when that's not what your thing is, right? Just because we're now asking about how does the ventilation in a building actually spread this thing. So I think the best thing is to try to direct people to other folks, say, you know, like this is up to the limit where I can speak confidently. And there's some other folks on this who can speak in the discipline that you are looking for is called environmental public health. Those are the people who know about HVAC. Speak to them because I know nothing about HVAC. Blah, 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 right? There's a question here from Mark Edwards. It would be helpful to have a sample B note. Is that something you could share? Now I'm very embarrassed. I don't have one at hand. I could try to find one sort of somewhere in my files, or one that we've worked on in the past. I don't have one at hand, but one thing you might do is, if you go to the advocacy groups that that are on the issues that you care about, they might have just a brief sort of summary of their position up top, like the one pager on their website. So we're advocating for more childhood vaccine or something like that, and we want the state to better fund access to trans health, and they'll have 6 or 7 points on their website about what our main priorities are. That's sort of the model of what I'm talking about.
Yeah.
It's the executive summary. It's basically the executive summary of a position paper, right? You go to a position paper, look at the executive summary. That's sort of what I'm talking
Yeah. It's, I would say it's very, very similar.
Yeah.
I don't see any more questions. Oh, Chris is saying staff members for state reps are also a good source to help you work through these. Okay.
Oh, I don't see that.
It's in the chat, not in the Q&A.
Okay. Staff members for state reps are, yes, absolutely, right? Staff, yes. And in fact, most of your conversations with the political level will not be with the elected person. It will be with her, his, or their staff person, their legislative assistant. So the basic titles are legislative assistant, chief of staff, senior policy advisor. A state rep or a congressman or woman will have an office of 4 or 5 people, and you're probably looking for the legislative assistant. A senator will have a lot more. A Senate or legislative committee will have their own staffs. So that's really what you're looking for. Someone who is on that. And if you're making the first call, just ask, is there anyone in your office who is watching this particular issue or this bill as it moves through the ledge or whatever?
Mm-hmm. Yeah. And again, I have friends who are they're aides to Congress people. And the way that they have just spoken about this person came to lobby on this particular issue, having done no research about why my boss would care about that issue. I just feel like it always comes back to that. So you're always thinking, it's always pitching. And Rob, there was a question from Katrine about whether the fellowship in global journalism will be a go, not this year, but she said 2021 to 2022.
Yep. So first of all, I hope that I'm not stealing folks from the Stanford Initiative. If I'm pitching this out, I think we do different and very complementary things. But yes, this thing is a go. It's actually the School of Public Health at the University of Toronto, which is the Dalai Lama School of Public Health, not the Dalai Lama School of Public Health. And I put the name in the Q&A or in the chat. Sorry, in the chat and in the Q&A, I think. But it's we're launching our next cohort in September. Excuse me, that is my accountant about my taxes. We're launching our next cohort in September, and then we'll start the September after that. And I have a separate program that is a part-time, less intensive program for health professionals and health scientists called the Certificate in Health Impact, which will start in October, but be much less intensive, sort of one meeting every couple of weeks.
How long does that run for?
That one will run for, we've done it for 2 years. We've done it for 12 months each year, but actually I think we're going to reshape it to do it for 10 months. And you are not doing as much journalism, so you don't walk away sort of as a working journalist, but you are doing enough, and you are also doing a podcast, a website, a podcast and radio show. You're doing enough that you've added these skills into what you do. We've had graduates from that program who are now running a race and wellness podcast up here, which has sort of been pretty center stage as Black Lives Matter has come on to the public conversation in Canada. So there's a lot of stuff to do there. I will put that in. You know what? You can get all of that just by emailing me. So I will put that in the chat again.
And we're gonna, before we break for 15 minutes, I just want to plant the seed for everyone that when we come back, we're gonna be talking more about that public intellectual role and what fears, concerns, anxieties you might have about broaching that, where you might land on that spectrum. So during the break, as you have your tea, you go for a walk, whatever you do, please think about how we might help you, and think about what questions you might pose to us.
First of all, wow. Again, I don't know quite, well, I know what to say. I have some thoughts. I'm worried about
people's lives. It's so sad, 600 healthcare workers have died from COVID-19 in the US. And some of that has to be down to the fact they weren't given the right equipment to do their job safely.
So here's what I would suggest. We've seen some of this up here too, where physicians, health staff, nurses, in Canada, most physicians are actually not employees of the hospital, so they have a degree of independence. They're independent contractors to the hospital, but I know that's not always the case in the United States. But this here is risen up a lot more with nurses and with junior physicians, residents, and so on, who are employees of the hospital. So here's the advice I've given to them. First of all, don't worry about this falling on deaf ears. What you've described is a very, very powerful story. The way actually that Seema described it, I would take a cue from that. Seema thinks like a journalist, speaks like a journalist. She presented something really counterintuitive and powerful here. Texas, the Texas area is the center, is the world's largest, has the world's largest, health complex. I did not know that. And it has run out of ICU beds. The crisis there is as grave as it ever was, I would say, from what you're saying in New York or in Italy. And it's all of a sudden, and it's in Houston. So this will be of interest. So what do you actually do, and how do you protect yourself in doing it? First of all, I think that you have to decide for yourself what the greater risk is: losing a job, or you and your colleagues, losing your lives, being at risk of an infection that could have really, long-term consequences affecting your patients and so on. I think that you can bring this to a journalist. And so what I would suggest is you happen to be in a state that has some really great journalists, right? In Houston, you have the Chronicle. You have, if this is a statewide issue, and my guess is that if it's not all over the state yet, it will be by, like, what are we, Tuesday? By Thursday, it'll be a statewide issue. So I bring this to the Dallas Morning News. Seema knows, Seema knows that place, and it's a great place, right? I bring this to the Austin American Statesman. I bring this to the Texas Tribune. Texas Tribune is inspired by ProPublica in a lot of ways. It is a major investigative outlet. These folks will put things on the agenda. And you can speak to a journalist. And if you need to speak, first of all, I would encourage you to find some way to think of speaking on the record, because it helps the journalist enormously. If you feel that you really can't, then bear in mind that the journalist needs to have a ton of detail. If you can't speak on the record, then the journalist needs a ton of detail in order to verify what you're saying, fact check it, believe it, and so on. So get whatever detail you can, and try to line up other folks, if possible, who could also speak and can describe. Tell them what the stakes are. Tell them, tell them what it means to not have an N95 or any other PPE. And I would get the word out to them. I would also, though, if you haven't done this yet, I would consider going up through the normal chain in your hospital, your hospital system. There's probably a normal chain, and maybe it's an HR chain or something, to put the complaints to them. Give them a chance to respond. It may be that the shipment came in. It may be that there's something in the works. It may be, God knows, that they're redeploying. So they did a deal with the Presbyterian in New York, and there's a bunch of stuff being shipped in. I'm making this up, but it may be that there's more to the picture than what you see in your unit. And if you bring it up through the normal chains, you'll give them a chance to respond. And if they have no response, then you can comfortably bring it out to journalists and to others. I would also bring it out into the profession, and that may be, and I don't know the governance of health in Texas, and maybe the state medical board, maybe the AMA equivalent in the state, or something of that nature. And frankly, if you're pulling all the stops, bring it to your state rep and bring it to your congressman or woman, right? Explain it to them too. So the idea is to get it out to as many places as you can, with as many facts and details as you can, having first gone through the channel inside your health system, to have given them the chance to tell you, look, you know what, we know, we've been on this, we actually have a whole pile coming in right now, who knows what the actual story is. But I think that if you bring it outside, people will be paying attention, right? I don't know what the solution is, but now that Governor Abbott seems to accept that masks are part of life, maybe there's some action that can happen beyond just the scope of what you are aware of. Sorry, I'm going on and on now. But.
No, I think, no, do go on and on, because it's really helpful. But I wanted just to alert everyone that watching this webinar is a phenomenal journalist who is Texas-based and writes for the New York Times, and is saying in the chat or the Q&A that she's listening, and that Mike can reach out to her. So if Mike wants to share their email privately with me in the chat, I can connect you with that journalist. People want to share these stories. We are all very frightened about what's going on. We don't want healthcare workers to be at risk, as they have been. We don't want the public at large to be at risk. So these stories, we rely on people like you being brave and channeling your anger and helping the rest of us be informed.
Here are a couple of ways to break through in terms of pitching the story. It sounds like Patricia already gets it. Most journalists will get it, but here are a couple of ways to sort of position this story to break it through. One is, Texas, you're not in the second wave, you're in the first wave, but you are a hint of what is to come. So if we do all believe that there will be a second wave that will hit the Northeast and hit other parts of the US, right? Then Texas's problems now in getting resources are a signal of how screwed. New York thinks it's through this. It's not a Texas problem. New York thinks it's through this. New York thinks that, okay, we can go back into lockdown in October for a few weeks. It's okay. We've done it before. Look what's happening in Houston right now. We don't have the basic resources to actually deal with this, to deal with the next round of this right now. So that's one thing. And I think, again, giving people a sense of the scope and the intensity of the crisis at least in sort of Gulf Coast, Texas, and probably, doing this right now will also give folks, a sense of what's coming for the rest of the South of the South and Southwest if we don't get a handle on it. I think it's a really important and good story, and I think you should move on it.
Totally. And it's completely connected to what we wanted to spend the remainder of the webinar discussing with you, which is, yes, over the last two sessions, over the last two Tuesdays, we've shared these skill sets with you. We've hopefully offered lots of context about what it means to think like a journalist, how we might counter false narratives, how we may not just use facts and pouring facts onto polarized conversations. But when we think about leaving you in the next 40 minutes to then take this information out into the world, what might be stumbling blocks for you? Because that's something we really would like to address. And Rob, perhaps as questions come in, shall we maybe use an example? For me, the one thing that I was thinking is that the way that you can leverage your expertise and your platform is obviously, as Mike's saying, sometimes it is dictated by your workplace. And from my own experience and from talking to others to do the kind of work I do, it can vary so much from being at a university where they really like their professors to be framed as public intellectuals, where every time you do a TV hit and the name of your university is used, they will literally calculate how many millions watched, what time it was seen, what the monetary value of that is to the university. And then there are other institutions that maybe for funding reasons, they don't want to upset donors or other political reasons, kind of don't want their experts speaking up, not unless they are towing the party line. I've certainly had those conversations with folks who've been on both ends of that spectrum. Does that sound familiar to you, Rob? Yeah. What other considerations might there be?
Yeah, and I've actually worn two hats here. I've been both, I started as a journalist. I've spent the last decade teaching journalism to health professionals, among others. But in the interim, I also ran communications for the University of Toronto. And while on the one hand, it was true, and we have a very large health complex at U of T, one of the top in the world. So while, on the one hand, it's true that we really were promoting all of our academics in all sorts of fields, we were also very nervous when anyone at the university was speaking about the university itself. Not that we were nervous about them speaking about the university itself, but that was a dimension that went sort of beyond normal academic freedom. It's like, if you're sure, you could say what you want, but do us the courtesy of letting us know how you're going to be criticizing the university in public. So here's what I would say. If you are going to be out talking critically about your own institution, and it is entirely appropriate in some cases to do so, first, I would urge you to go through the normal channels in your institution first. Said first twice. Because one of the things is, you may not know actually the breadth of what's going on in your institution. We are all so focused, right, in our own area, in our own unit, on the disease. We're working with our own patients, on our own teams. We have no idea, particularly in a large health system or a large health business, what's going on all over the place. So get your own sense of whether you are experiencing something acute in your area or something that is more widespread. If it's acute in your area, it may be that you can actually solve the problem without having to make it public. And that way you actually, you address these concerns and these risks. You don't have to shame people into, that's sort of a last resort in a way. If it turns out that there's no solution or that your institution itself is sort of stuck and they don't know how to move forward, that's when you can actually, I think, comfortably go out with it. You should also be aware of what your rights are and how you're protected. A lot of folks will threaten, a lot of folks will say you won't get an advance, you won't be advanced, you won't be promoted, you won't blah, 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 blah. Most people's work is somehow protected by labor law, their professional codes, their employment agreements, their, and simply threatening you is not tantamount to actually being able to do anything. People will say things in the heat of the moment. So know for yourself what rights you have and the scope of action that you have, particularly as a professional, to be able to speak. There are sometimes, if you're a public servant, it is difficult actually to speak publicly about the government. You're not supposed to. You're a public servant. But under those circumstances, if something is really bad, there's also whistleblower protection. And you can speak to journalists very confidentially too. Be careful about that. So I would just say, generally speaking, know your rights. See if there's something you can do internally. And don't let yourself be bullied on the one hand, but on the other hand, don't always reach for the gun, as it were, because there may be other ways to make the change that you need to make.
That was great. I think there are often many different approaches, as you've outlined, although it can often feel like there's only one way when you're that person. I'm not seeing any questions yet, Rob. I've asked folks again. I'm just thinking, I'm really curious what you will take moving forward from this, like which skill sets might be most pertinent to you at this particular time. And again, we want to kind of speak to your concerns and fears about engaging in public advocacy. Any other considerations come to mind, Rob?
I think the one thing that we don't talk much about is just the time commitment. And we it's easy to sort of talk about
Yes.
The ethical issues and the principles at stake and all of this. But man, just even ceteris paribus, when everything is nice and is good and we're allergists just talking about pollen season, takes time. So you're the person who's balanced all this stuff out. How do you manage the time between being an academic physician and doing journalism?
That's a great point. And as soon as you said it, I was like, yeah, we don't talk about that enough. I think I probably have a bit of an unhealthy work ethic, but it comes from the fact that I really like what I do. And I think I talked last week about like my aha moment for wanting to do your journalism program was because I was so frustrated in the trenches, seeing particular issues that I was like, why is nobody talking about this? Or are they? And I'm just not part of the conversation. That was my whole motivation for going to journalism school, was an absolute extension of my role as a public health physician. And my appreciation as a disease detective at the time that journalism is part of the public health ecosystem. Why were we pretending like it wasn't? Why was a good day at the CDC a day when you didn't have any interaction with the press? Why weren't we going forward and saying, hey, Americans, your taxes pay our salaries, here's what we do with it. And it didn't have to all be crisis mode, right? It could be like, here's a prevention thing we just did, here's a vaccination campaign we just did. And I was so frustrated by that not happening. And also, I was really frustrated that whenever I got sent to investigate an epidemic, I had a very singular focus on containing the pathogen, when I was clearly seeing and hearing that there was all sorts of misinformation that was fueling the spread, but that we were told, no, that's not your concern. And I was thinking, why? This is so bizarre that the two are spreading in tandem. We need to address the two.
Yeah.
And that was my motivation. And so I bring that up because, one, I think it's good to know where people are coming from, but I'm very passionate about this. This feels like my life's work. And so that's why I end up like maxing out and working a lot, but also I really like writing. I like the challenge of, okay, here's this thing that I really care about. How do I translate all this complexity and nuance and sometimes counterintuitive things into a way that's not only palatable to you, but makes you sit up and makes you think, wait, I care about, why isn't everyone talking about this? I need someone else to read this article. But then I've certainly had challenges when I talk about, I ended up in the middle of that public intellectual spectrum. I ended up as half-time a reporter, half-time a professor. I remember like being so maxed out and my mum saying at the time, oh, didn't anyone tell you that when you work 2 jobs at 50% each, it's really 2 jobs at 100% each? And I was like, no, that would have been useful to know ahead of time. Then you get really good at time management. And also, I think physician medical training helps because you get really good at triage. So at any given time, yes, you will have 5 competing priorities, but they're not all the same kind of priority. So I think it's good time management skills, good triage skills, remembering why you're doing what you're doing and just tapping into that passion. And of course, as a reporter, I would sometimes get a given story that I wasn't that passionate about, but then my motivation was like, I'm just going to try and find the nugget in this that's really interesting, and I'm going to get it done so I can move on to the topic that I really want to get into.
Right. Yeah, I know that it's difficult. I don't have to wear those two hats. And in fact, I'm like the cobbler who, with the cobbler's kids, the guy who gives the advice and then doesn't follow it himself. So I've not been writing much in the last long while. But I think it's, what I also tell people is to be very gentle with yourselves, right? On all of these dimensions. Be gentle with yourself when you think that you are going against your profession. Be gentle with yourself when you are worried about ruffling feather. Be gentle with yourself with your time when you need to break, right? Because we're also all, particularly folks who are on the front line of COVID or sort of peripheral areas of COVID, we all actually need breaks. Summer is the time that we were supposed to get one. Most of us aren't. So be
maybe you demoed with age, because when you were teaching me the program, at least you were very like, publish, publish, publish.
No.
You wanted us to learn by doing. So we had to be constantly pitching and writing and reporting.
Well, there's another piece here, right? Which is that I've also learned from mentoring and, if you will, running sort of novice journalists who are starting out, which is a lot of your stuff will not get picked up. A lot of your stuff will not get accepted. So I think this is actually quite an important point. And it's the same with art or any other creative endeavor. It's probably the same with grants, right? When you're writing grants at an early stage of your career, a lot of your stuff will not get picked up. So keep going and keep pitching. Make sure that you have a bunch of ideas at any given time. If you want to do this work, right? You have a bunch of ideas at any given time. And just know that if you are, it's sort of like baseball. I know that a lot of non-Americans here and non-Canadians, but in baseball, if you hit the ball 3 times out of 10, you are one of the superstars in the sport. It's the same in journalism. If you actually get a story picked up 3 times out of 10 and you're pitching as a freelancer, as an independent reporter, you're a superstar. So recognize that and don't just hang everything on 1 or 2 ideas. Keep looking for other ones and keep pitching. But I've also recognized, that because we're not in control of what gets picked up, I've become a little less hard driving in that respect. Interestingly, the less hard driving I am, the more the numbers in the program go up. So there may be a correlation.
Say that again, the less hard.
I'm being a little cute about it, but the less of a jerk I am about this stuff, the more people seem to want to come to the program. So
maybe it's good training for being in a newsroom. Actually, no, my experience of newsrooms is that they're not places like that. There's some good questions that have come in.
Okay, good.
Including one from Katrine. Katrine says, research has shown that many scientists do not receive social media training or adequate training in science communication. What are your thoughts on this? Katrine, this is why I do what I do. It's why we are so passionate about our work at the Stanford Health Communication Initiative, because over and over, we see the failures of that lack of training. I can just pick one example out of the air. Think about the human papillomavirus vaccine. What an amazing scientific achievement. Literally a vaccine that can prevent cancer. Oh my goodness, who doesn't want that vaccine? Who's eligible? Well, it turns out loads of people. And partly that's because of our failure in the public health community to really frame the messaging around that vaccine. It's a cancer prevention vaccine. We went in with a ton of messaging around sex, sexuality, and young girls. None of which is bad in my opinion, it's real life, but that really triggered so many politicians and so many parents who didn't want to talk about young girls, didn't want to talk about STDs, didn't want to talk about sex. And we could have mitigated a lot of that HPV anti-vaccine movement, I think, by really just thinking about how the messaging would land.
Yeah, so to pick up on that, one of the principles here, and this speaks to this sort of advocacy piece more than the journalism piece, the reporting piece, is good ideas don't sell themselves. I gave a talk back in November to a global management consulting firm, to their public sector practice area. And these are folks who come up, and a lot of them, in fact, a lot of their work is in very complex health systems consulting. but they work for all different parts of the government, military, education systems, and so on. They tend to have really smart ideas. They're smart people. They have a lot of time to invest in research, and they have smart ideas. And then they take their smart ideas and they just go like, put them out there, and they're shocked when they produce antibodies and a cytokine storm of response. And it's because they expect the smart idea to sell. It's a smart idea. Of course they'll sell it. Everyone will see it, right? They don't sort of think first, how's this going to land? What parts of the community are sensitive to what I'm about to say and the way I'm going to say it? What are their concerns? How can I address their concerns, right? So I'd say that that's a big piece of science communication, exactly what you're describing. In terms of social media stuff, I have to say, I've tried to figure out how to teach this. I have not figured out how to teach this. Maybe Seema has figured out how to teach this. My only sense of how to teach it, first of all, the platforms are changing all the time. And I don't think that there may be rules and best practices. I've sort of sat in a lot of classes where people talk about them. My sense is that it's just a matter of doing it, just jumping out and doing it and just sharing content, deciding if you even want to do it. You don't have to participate in social media. But watching social media at the very least, or reading it, gives you a sense of where the conversation is.
Yeah, I really like social media. Yeah, well, I really enjoy social media, so I think my engagement with it comes off in that way, like it is genuine. I enjoy my time on Twitter and Instagram. But you know how people often frame that as a waste of time? I find it really useful. As a journalist, I found sources on there that I may not have interacted with in any other kind of network, not in real life, not for me to try and find those sources. So for me, it's been really helpful in that way. Sometimes when I've had to try and track down a person, people put their lives on social media. It's an incredible and I know I've sat in cars before, like racing to the scene of an incident, and wondering how journalists did journalism before social media. Because by the time I turned up to a place, I knew the person's grandmother's name and what they had for breakfast literally that morning. Um, but social media, I think, can be a very powerful tool for advocacy. And I think it's why, coming back to this idea of institutions sometimes censoring or policing their staffers, it's why that we do see these strict social media guidelines, both for practitioners of medicine and people in the healthcare field, scientists, but journalists too. Now is the time to be having this conversation in particular, because it's been all over the New York Times, Pointer, Columbia Journalism Review about how journalists use social media right now. I got into lots of trouble a few times when I was a newspaper reporter for the way that I was tweeting about certain public health crises. I stand by that because to me, the whole idea of journalistic objectivity and neutrality was crap. I was coming to my role as a science newspaper reporter as somebody who understood the mechanics of the 2015 HIV outbreak in Indiana that happened because then Governor Mike Pence defunded crucial places for HIV testing. So yes, if I was going to tweet about that, I was going to be angry. My editors felt I had crossed the line. They asked me to delete the tweets and I refused to, because as far as I was concerned, there was significant evidence that then Governor Pence's actions had fueled an historic, tragic HIV outbreak. So we are constantly treading those lines as regular journalists, as scientist journalists. I think the conversation has to evolve and continue, because it's tricky stuff. And that whole view from nowhere journalism, I don't buy it. I don't think it's ever existed. I've been doing a lot of digging into the history of American journalism. It's never been neutral. This idea of like make journalism neutral again, it's false.
Yeah, I agree. Seema, there's a question here for you actually. Can you talk about your approach to curating your social media to get the most credible scientific and health information? I'm actually going to pull out my pen because I would like to know the answer to that.
Well, sometimes I'm not searching for just the most credible, right? Because the story might be about misinformation, in which case I'm really interested to find out why a group of fathers in Scottsdale, Arizona is picketing against the use of masks, right? That they might go against my beliefs, but I don't want to filter them out of my social media experience, because I want to learn what they're saying to each other, why they believe so passionately that masks are a form of social control, for example. When I teach journalism, I never tell my journalism students, you must be on social media. Whereas if you go to newsrooms, oftentimes you will be forced to set up social media accounts if you don't have them, and you'll be told things by editors like, you must share and tweet out 5 of our stories per week. There are these weird quotas. I think when you tweet and engage on Pinterest or Instagram or anything like that, it just comes off as really robotic. There's an element of social media interaction. Actually, I learned this from your training, Rob. I think you had someone come in and talk to us. It's some element of it has to be human. Otherwise, we're just reading, I think, any other kind of news feed, and actually, that's not what social media platforms are about. So my advice is only to engage with them if you think you're going to like have a go, and if it's abhorrent to you, it's a time sink, it's very negative, it's depressing, which some studies show Instagram is for some people, then I wouldn't worry about it. I think yes, you will miss some things, but maybe you won't miss that significant a chunk of what's going on. It comes across if you enjoy it and your engagement is authentic. I enjoy it because I found sources on there. I've learned so much from incredible scholars who are brilliant at distilling complex ethnographic studies into, 6 linked tweets. So for me, it's Twitter especially is magic.
How do you curate your list? How do you know what to like? Where do you find your stuff? If I'm starting de novo, as I sort of am because I'm shifting my own work at U of T, and going into a different kind of uh, uh, role where I'm interested in different kinds of things. How do I go about starting off with my feed and what I'm listening to, what I'm watching?
2 things. One is set up your bio so people know who you are in a way that's going to engender trust with you or engagement with you and follows. But the second part, like curating the list or your feed, that's actually quite easy because there are people out there who have done that work for you. There's a phenomenon on Twitter called lists where people have already created, oftentimes in the public domain, um, lists of thousands of Black women journalists, lists of science journalists, lists of women in India who are engaged in reproductive health activism. Those lists are out there. You might have to do some digging to find them. You'll eventually come across them, and then you click follow, and you will already be following 1,000 people, or 100 accounts or something. So that part's not too hard. And then it's just spending some time on there, engaging with people, seeing who they are engaging with, and that's how you start to build it up. And I really appreciate people who make the time to be there because the more credible sources of information we have on there, the more experts we have, it does start to counter some of that misinformation that's spread on there. Yes, some of it is by bots, it's on huge levels, but other times it's the kind of engagement that you have one-on-one with a patient in a room. You can shift somebody's perspective through interactions on Twitter, believe it or not.
Yeah.
We have about 10 minutes or 15 minutes maybe to start to wrap up. I like this one comment from Marina in the chat where she's saying that she immediately applied the rules of engagement that we talked about last week for redirecting the spreading of misinformation and engaging in dialogue with relevant information rather than bitter yapping at one another. So that's a useful way to know that this information is taken forward.
I'll pick up on the next one there from Jeff, who quotes Professor Rebecca Sachs. Most of your ideas are terrible. It just prompts another quick thought. Something to know that when you're communicating with journalists, and the same is probably true of political staff, these are two very curt professional cultures, like really curt. Like they don't answer emails. They don't follow up. They have 2 or 3 seconds to speak, unless you are somehow really important to them in that specific moment. And you may have been really important to them 2 weeks ago, but you're not important now. So for folks who are used to working collegially, or, and this may be particularly true of academics, who are used to sort of long exchanges and collegial blah, 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 where there's always often, a little subtext of passive aggressive bitchiness, excuse my language. This is a very jarring kind of thing. And I'm reminded of a classmate of mine from McGill who went on to be an editor at the Sunday New York Times Magazine, who, when he was leaving, put out a bunch of tweets. And one of them was, my apologies to all of those who never got a response from me, and who thought that I hated them. I only hate about 0.1% of you. 99.9% I didn't even see your email. So just remember that it's not personal. It's a curt, very fast moving kind of environment. And the basic way that editors think and function, I found, with a great deal of affection to them, and I'm actually sort of one of them, is you either have your blinders on and you can only see what's immediately in front of you while I'm editing a story, so I can't take all of those emails coming in I don't know, and then the blinders come off when I'm done, and I have 700 emails, and I realize I forgot to pick up my kid at school 2 weeks ago.
Oh no.
I'm not going to answer you, right? And blinders come back on when I have my next deadline. So just go with that.
You do develop a thick skin, but also I think for us as scientists and practitioners, for many of people watching today, like you said, we have most of our grant applications denied. Most of our experiments in science fall apart. So it's just applying that same mindset of just you carry on, you keep pitching, you keep trying to make people care.
Yeah, and the nice thing about this, by comparison, is the turnaround times are very fast. You know, you're not working on an experiment for 18 months and then realize the date
Yeah.
didn't come in, or 3 months on a grant application and realize you don't get it after waiting for 4 more months. This is like, okay, I worked for a week on a pitch, I put it out there, no one answered, I'm on to the next one, I'm on to the next one, I'm on to the next one, right?
And you don't always stop though, because I'm in that situation where an editor really liked a feature pitch for a magazine that I had spent a lot of time pre-reporting to make it a really good pitch. They loved it, but they couldn't get buy-in. Then I sent it to somebody else and they were like, oh, we're going to kick ourselves. We're not, accepting this, but we can't. And it's been a month or so, but it's still relevant. And so I'm still thinking.
And there's always more places, right? It's not, in science, there's the NIH, the NSF, maybe 4 or 5 other big places that could give you the grant that you're thinking of. But in journalism, it's like, okay, there are dozens of places that you can pitch to. And then the temptation is to keep going with the same idea and keep sort of flogging a dead horse if it's a dead horse. So anyway, it's a different kind of culture. Be very gentle with yourself as you go through it. People are not particularly polite. They won't take a lot of time. But the currency is in the idea. And if you have good ideas, keep banging them out and keep sending them around. When feedbacks are constructive, it just makes your paper better. So at the end, the late article is great. Yes, particularly if you have a good editor.
Oh yeah, good editors are golden, and that can be even if they're like, this pitch isn't for us, but they might give you even some feedback on it in some rare instances.
Yeah.
I'm looking at more questions. So this is an interesting one from an anonymous attendee. It says, publication could be stopped or delayed because ad companies finance some journals and don't want bad news close to their ads. This impedes the range or topic of articles these journals can publish and could bias the message of articles published. So I think when you're saying journal there, the attendee might be talking about scientific and medical journals, but in general, there should be a line between the business division, the opinion section, and a floor even, and the reporting that's done at a particular, I'm thinking of newspaper, television, from my experience. What would you say to that, Rob?
I agree. Most news organizations are really, they have the value embedded, at least in North America, I would say. I'm less familiar with the UK, but I think it's the same. I don't know about the continent of Europe, but I think the same principles apply in most of the democratic world. That this risk is a long-standing thing of which people are aware, and news organizations are structured to mitigate it. That doesn't mean it's always solved. I've had 1 or 2 experiences in the last decade where we had a good story that couldn't run because the owner of the publication was actually connected to the person we were proposing to write about, and it was never made explicit. But when I realized, in this case, is such a perfect story for this particular outlet in this city, why not? And I sort of spent 10 minutes and I realized, oh, it's because these 2 guys are actually business partners on 5 other businesses. But then I thought, you know what? In that case, we actually ran the story with the Atlantic. It ran in a totally different place, had really good impact, and it wouldn't have been really good in the original place where we were offering it. So I was sort of, in a way, happy that it didn't run. But generally speaking, I don't find, I've never seen an example where advertising has killed a story. Sometimes owners have a particular view or a particular perspective, but I think that's less and less the case. So I wouldn't worry too much about that. There are political views, though. Like there's some news organizations that feel like, we are a Republican news organization, we tend to be Republican in our perspective, and this just won't really fly here or whatever, right?
I was just going to say that, and I was going to say the bigger issue isn't about advertisers or anything. It's just to do with the particular biases and perspectives as your editor. So you're saying, here's a story that I've seen on the ground. I think it's really important. Your editor can be like, no, we don't think that's newsworthy.
Yeah.
Which is what makes the media so powerful, right? Gatekeepers of all the news that's fit to print, as it says in the New York Times front cover. And that's why we need you to do some of this work, because you have this very special perspective and you have particular lived experiences that can really inform your stories and make for very rich storytelling.
Yeah.
So in the last few minutes, we'll keep checking for questions, but we would like for you to stay in touch with us. We will be doing more CME trainings along these lines. Definitely thinking about the fact that Katrine brought up that so many of us who went through rigorous scientific and medical training don't get very good communications training. It gets sidelined as a soft science, something that you just pick up. But there is a science and art to effective communication. There are significant consequences and impacts of how we communicate. So we will be working with Stanford CME office to continue doing these trainings. And a lot of it we will do tailored to what you need. And in part, this webinar series came about because faculty were saying to me, COVID-19 is such a crisis of communication. What can you teach us to just have better patient interactions, better peer interactions? What can we do to get our truths out there in front of the media? So please do stay in touch with us. There'll be a post-evaluation survey. We'll be looking at that closely to think about what your needs are moving forward and what more we can do.
I have one last question for you, Seema. Do you actually play the harp, or is that decorative?
I do play it, and you would think that under working from home conditions, I'd play it a lot more, but it's been so busy that I've neglected it.
You're the only harpist I actually know. That's awesome.
It's such a beautiful instrument. I love it. It sounds amazing, but I am busy writing.
I'm so grateful that you invited me to be part of this, you and Jonathan and Jazona and Megan, thank you. And Justine, thank you for all of the work to pull this thing together. This was really, really special. And likewise, if I could be of any help to anyone, I put my email in the thing a couple of times. Very happy to chat. You can always just look me up. And I hope that we could be of service as well.
Great. Well, thank you. Thanks, Rob. We really appreciated your joining us here at Stanford. And I'll always be sure I say the right name of your organization. Even though it sounds like the Dalai Lama, I'm sure it's just as peaceful and calm.
Yeah.
And thanks to Seema, my colleague, and both of you for a wonderful job. Also, thank Justine Schultz for her great help preparing our slides and organizing this, and Jazona and Megan for organizing this with the CME staff. And also like a shout out to the Stanford Center for Health Education within the group that we reside here at Stanford and their leadership for their help and support. So thanks everybody. Stay well, stay safe. Bye-bye.